I call this a patient-centric concept. Now in medicine is becoming more personalized. It's becoming, patient-specific. So each treatment plan or procedure or therapeutic protocol is based on that specific patient and is made tailor-made for that specific patient. So this is how I look at my cases too. Now, in general, we have, a set number of types of procedures that we do or techniques for bone augmentation, but usually based on the patient themselves, some of their biology as well as social history, medical history is all brought in together to decide on which approach I use for the bone augmentation procedure. And this concept in general can be used for any type of treatment or care, not specific to bone augmentation. So for me, a patient-centric treatment plan basically allows me to be more predictable because the approach is dependent on specific things, biological factors of the patient as well as socially influenced factors and as well as the patient's expectations. So all of these are brought in together to mold my thoughts and my treatment plan into a tailor-made result for that specific patient. Now, how do we bring basically digital work into this? So digital comes in, digital allows me to do my surgical planning a little bit more accurately. I think as humans, or me specifically, I'm a very visual person. So when I look at something, the common phrase that they have, a picture is worth 1,000 words. For me, if I have an image or a visual 3D model of something, it allows me to think in multiple ways in an instant just by looking at that one image. So digital planning gives me this tool. It allows more improved visualization of the defect. Because sometimes when you're doing a procedure, looking at the defect intraorally and looking at it on a 3D model or a 3D printed model in your hand are two different things, and you can see a lot more when you can see the entire area. And so digital planning helps with this. Digital bone grafting itself basically creates a virtual volume of the bone required for the augmentation cases. So I'll show you, what I do with some of my cases is I'm deciding to create that tailor-made plan is I look at the defect, I digitally create the volume that I need, and then I look at that volume based on what we have and where we want to be, and that difference is what I use, and I decide, okay, well, this is the type of defect, this is the volume needed, and so I decide based on also other things. Sometimes there's social history, whether they're smokers and compliance and things like that, all come into play to decide what's the best technique in the procedure for this specific patient. It, like I said, it helps with my appropriate technique. And then in the end, all of this, what this does basically is it allows your procedures to be a little bit more predictable because you've looked at a lot of factors prior to even commencing the treatment. And because you sort of know a lot more before you go in, it makes your procedure more, you're more efficient and you're more precise with your work. And the surgery is usually depending on, I'll show cases where some of the bone blocks, the way we make our osteotomies, everything is pre-planned. And so the surgery is actually much faster and smoother, and there's less guesswork because it's all been digitally planned. And I'll show you how we do some of this stuff. So this is my basic workflow for most of my augmentation cases. Initially I see them in 2 visits. So I see them in the initial visit, which is when I just collect my data. We look at your medical social history, any radiographs, clinical photographs, impressions or intraoral scans, CBCT scan. And then I go over just the patient, I talk to the patient. I see what their expectations are, how their fears are, whether they're really afraid and really adverse to like a larger procedure. If someone is really fearful, then we try to keep our techniques and procedures as less invasive. And I may think of, a GBR approach as opposed to a block graft. So all of these things kind of come into my thought process when I'm deciding what I do. So once I gather all this information, I then start my analysis, and this is where I do my digital planning. We decide, from speaking to the patient and the referring restorative doctor, we know what the prosthetic design is. I analyze the soft tissue, the bone, and also the patient. Patient analysis has to do with their medical history, their social history, and just their overall demeanor, how they are. Like it's, for someone who's a little bit hesitant to go through a bone grafting procedure, I'm not going to do a very aggressive, you know, multiple bone block technique on this patient because they're already a little bit timid, and to have them go through a rougher post-op period is just going to make them really, really upset and unhappy. So things like this do help, you know, and sometimes, you know, you can get similar amounts of bone using a GBR approach as opposed to a block graft. So sometimes I may choose one or the other, and all of them work. You just have to understand, you know, principles of regeneration, understanding, you know, space maintenance and things like that. And usually you can even do wonders with the GBR approach as long as you follow the principles. So once I've made my analysis, I see them for the second visit. This is usually once I basically have formulated my treatment plan. If it's a digital case that I've pre-planned digitally, I go through some of the digital models with them. I show them what I plan to do, you know, and you'll see some of this in images on the slides in some of the cases, how we explain to them the need for the graft. They get to visually see the graft, and then they you know, we talk about it. Once they understand the treatment, they understand why I'm recommending that specific approach, you know, we wait for the patient to get approval. And then once they're good to go, then we're ready to book surgery. Okay. And execution means surgery time. So today's topic is mainly how we digitize these cases, how I take a case and say, you know what, how am I going to bring this onto the computer and virtually do the surgery? And so the way we do that is through making the patient digital, you know, a digital workflow to basically digitize that patient's mouth so that I can bring it on the computer, manipulate it, and start to do some of my workflows to decide what's best. Now, a little bit of background history. I'm technically, you know, I've done a lot of this, but there are other people that have done some of this stuff. Uh, some of the ideas that I've got are come from, you know, my surgical planning itself is actually, you know, from orthognathic surgery. You know, oral surgeons use a lot of this orthognathic surgery to do their larger reconstructions, especially when they're reconstructing tumor removals, and they also doing orthognathic cases. They use companies that do these virtual surgical planning. Now, the problem was when I started to look into this is, you know, if there's any oral surgeons here that know that this costs a lot. It's usually, you know, sometimes $2,000 to $3,000 just to do that virtual surgical planning. And that's done through an external company with biomedical engineers that help you and do the planning for you. And then you sort of log on a computer and do it. So it wasn't feasible for me to do this for a simple, you know, $2,000 augmentation case. It just didn't make sense, you know, to pay for the surgical planning when it costs more than the actual surgery. It wasn't feasible. So that led me down this path to say, you know, how can I do this myself? And through that, we I sort of came about some of the techniques I show. Uh, Another person I should give note to is Luca di Stavola. He's an Italian surgeon. He was the pioneer to start making computer guided bone block guides. You know, he published an article. I saw a case and I was like, oh, this is really cool. And back then, this is long time. It's been, I think I've done these cases probably 7, 8 years ago. So they're actually old, but it's becoming more popular now. But we've done it a long time ago, and he's actually done it a few years before me. So when I read his article, I did the research, and I ended up finding out that he did it through a specific software, which was a company out of Italy. And here in North America, that software and that company, they weren't approved by the FDA and Health Canada. So I couldn't have access to it. You know, I spoke to the guy who had the software, and he said, I can give you like a temporary one, but we do the work and we bill it to you. But right now our software is not approved for your country and your region. So I didn't have access to it. So from that, I decided to say, okay, well, you know what? I see the technology. I know a little bit of digital. I'm sure we could make it work. You know, if you can make a surgical guide for an implant, there's no reason why you can't make a surgical guide to harvest a block graft. And so after a little bit of playing around and with some help with my radiologist, who's a pretty smart guy, we figured it out. And so again, I have to give you know, Luca his thing. It's his the originator. He's a pioneer, but I was able to kind of find a way so that everyone can use it. And the way I show you is easily done by anyone. It's done with free software. You don't need to have anything. You can download the free software online and you can do it at home. And it takes about 2 hours to do some of these cases with some virtual planning, but it is possible. So we've sort of unlocked it for everyone to use. So digital data gathering. So what do I do to digitize my patient? So whenever I see an augmentation case, I gather these things in order to be able to create my virtual patient. So one is my workflow. Okay, so first is I get clinical photographs. I take an intraoral scan. If you don't have an intraoral scanner, you can always take a regular impression and then get the lab to scan your impression so that you can upload it. A CT scan, okay? And through the CT scan, we have our DICOM data, and we can make STL files, which are 3D files of the bone and the jaws. And then if it's an anterior aesthetic case, I don't do this all the time, but for anterior aesthetic cases, you can take a facial scan, okay? So here's the patient. This is just an example of one patient. We'll just go through just so you can see what the workflow and what the images and everything look like and what the files look like. So these are just JPEGs or RAW files. These are just regular clinical photographs, okay? Usually take a facial one, intraoral ones, patient smiling, then a intraoral scan. This is just done with the intraoral scanner. We here have a Trio scanner in the office, so it's quite easy for us to just do an intraoral scan really quickly. Sometimes radiologists can do it when they take the CT scan. Sometimes you can just take an impression and send it off to your lab to scan it. Okay, so there's multiple ways to get this data. All you need is the STL file. Then the CT scan. So the CT scan basically gives me DICOM data. Now the DICOM data can be seen in slices, or it can be used to create a 3D model. So the 3D models can be segmented out of the data in the DICOM files. And these segmentations can be done by you. It takes a long time, or there are companies that offer this service that can segment the teeth and the jaws for you. I usually use the service because it's much easier. I don't want to sit there for 2 hours trying to segment every detail. So by taking that data and you can segment, you can create a model of the jaws and teeth. Now here, keep in mind, I want you to note one thing. The teeth are not as accurate as they are when you look at this. So in order to get an accurate measurement of the soft tissue surface and the teeth surface, you have to have an intraoral scanner impression. The virtual segmentation from the DICOM data doesn't give you an accurate representation of teeth surfaces. Okay, you get your bone surface, but teeth, it's never as accurate because lack of being able to segment every detail and contour. So that's why whenever we want something that's on teeth or resting on teeth, for example, some of the guides are tooth-borne because it's the most stable and reproducible and more accurate form of guides. And so we have to have a intraoral scan or an impression scan. And then the facial scan. The facial scan now, this is an old facial scanner. Nowadays, the new iPhones have an app and you can actually just, scan your face with the app. Okay, so this has become a lot easier. And then these scans now can actually be brought in. A lot of now CBCT software can bring the scan into the CBCT software and layer it and align it. So you can have a facial scan, the intraoral scan, the segmented models, and the DICOM data and the CBCT all layered in your software. Okay, Blue Sky Bio is a free software, and Blue Sky Plan does this. So again, a lot of these cases that I show are done just with Blue Sky Plan because I want to show something that's accessible to everyone around the world. And because it's free software, everyone can use it, and it's for free and easy to do. So here's just showing how we have our CBCT, DICOM, and STL data. And then what we do is we've overlaid the intraoral scan with it. So now I get the actual accurate soft tissue profile and teeth with the bone. These are just different views, so you can see left to right. And then these are in layers. So actually in your software, you can kind of cut or make each of the layers translucent so you can see through. And this is just a little video you can see. So this is just the 3D model. So literally it's almost like you have a model of the jaw. Okay, and you can actually take out parts of it. You'll see we can remove and segment out the teeth. And so this is what it looked like if you did the extraction. So now it's like we've done a virtual extraction, and you see now how much bone you have. And now you can decide. Like cases like this are usually full arch cases where sometimes we do some alveoloplasty and do a full arch case with immediate load. Sometimes, you can see whether there's enough bone and whether you can do the option of an FP1 case and have it where you don't have any pink porcelain and you're able to build up the bone volume and place implants on bridges. So doing this virtually allows you to have options and see, okay? And then also through the photography, you can overlay some of the CT scan data and the STL files or the 3D files over the face so that you can just align and see how things kind of fit. These are more for just visualization. It's more for aesthetic cases. In our surgical case, unless we're looking at the teeth and the smile line, it doesn't really have much use for bone augmentation. It's more for cosmetic cases when they're looking at teeth and smile line and curvature and things like that. Like DSD app and all these similar apps do these things. But again, like I said, you can do all of this in the free software in your computer as well. So then here we can also now merge the facial scan with the jaws. So you can align it so that you have your facial scan, and then internally you can see the jaws are there. So here's a patient's facial scan and there his jaws. So now it's like I have a computer generated virtual model of the patient on my desktop. And now based on all this information, I basically have a virtual patient. So from this, we can take it to the next step and start to simulate our augmentation and decide where our implants are going to be, what the teeth, the new wax up is going to be. You can also have wax ups done and scanned and actually overlay them over the existing so you can see where you want to be and how, where what you need to get there. So this concept, this what I call virtual surgical design is the concept of sort of starting backwards. For a case, we use this specific case, an example is that everything is prosthetically referenced or guided, meaning that we do bone augmentation and we place implants in for the sole reason of getting teeth. People don't come in and tell you I need bone grafting done. They come and say, hey, I have some missing teeth, I'd like to replace them. So when the patient comes to me, I look at a case like this and I say, okay, well, this is what you have, this is what we want. So if we virtually place the teeth, now this is just done by me, so it doesn't have to be exact. But if it's a complicated case and if you wanted to have the crowns exactly done, you can get the lab to do a proper wax up. Some labs are digital, so they can actually do a virtual digital wax up for you. Others can just do a regular wax up, and then you can just have that scanned and then upload it in. So if you need more accuracy, you can do it one of those ways. If it's just a general idea, you can just virtually use the CBCT software to just input crowns in place. So here we have our crowns in place. Now, based on our crowns in the position, we then put our implants in. So you can see the implants there in the purple. So this is where ideally we would like our implants. So when we look at this, if this is where I'd like my implants, I can see the deficiency in the bone. So now in order to allow ideal implant placement, we have to build up the volume so that these implants are covered in bone. So virtually, what we do is we create a digital bone graft. And so now this digital bone graft, I show it separately, and we've shown it in different views because it gives you an idea of where most of the augmentation is or needs to be. So if you look, this is what we're looking for. We want an augmentation that gets a result like this, ideally. And you can see that majority of it, it looks like it's mostly vertical. If you look at the layers of the bone graft, you can see it's thickest towards a coronal portion. So that means that this is a vertical augmentation case. So based on this, now when we put it all together, we have our crowns or the augmented tissues and the ideal implant placement. Now I can use this information and decide on what's the best way for this specific case to have this type of augmentation. And you can take it a step further now to take it from a virtual to an actual tabletop model. And 3D printing does this. So here we've 3D printed that specific jaw model. You can see I've isolated the nerve as well, so you can see exactly where the mental foramen is in the nerve is. And this helps especially when you're working around that foramen, which we are going to be. And we also have our virtual bone graft printed. So you can see in blue, you actually have the bone graft. So what I did in this case, I don't have the photographs here, but we actually ended up using a titanium reinforced PTFE membrane. And I put the bone graft onto the actual model. And then what I did was I put the membrane over it and I cut and trimmed it. I trimmed it so it looped around the mental foramen and the nerve. and had it preset. I had already decided exactly where my screws and tacks and pins are going to be to hold it in. And basically all this is done. You can do it, while you're freezing or anesthetizing the patient, so that by the time the anesthesia is ready, you literally have a trimmed model. You know exactly where your screws and everything are. Your membrane is done. It's just a matter of opening up the site, releasing the flaps, popping in that membrane, adding the particulate and autogenous bone mixture, and rolling it over and screwing it. So all this planning is done ahead of time. Even the shape and everything of the membrane can be done ahead of time. So it makes the actual procedure, something like this now, when you have all of this, could literally be 30 minutes in and out of actual surgical time. So it just makes it much more smoother, more predictable. You already know sort of where you're going. It's sort of like a GPS navigation, like you've done a test run and now it's just doing it for real. And that's what this digital planning does. It sort of gives you a virtual test run. So based on this type of planning, you can do pretty much anything you really want. Okay, so meaning that it doesn't have to be even bone augmentation. You can plan your implants, you can plan your position. So once you have a virtual simulated patient model on your computer, you literally can look at all aspects of that site specifically and plan and do whatever needs to be done. So in this case, I'm just going to show a socket shield technique just so that you get an idea of how the digital planning helped me do the case. Okay, here's it's a fractured canine. We did our digital modeling, and you can see our intraoral scan, and you can see a little bit of the bone model layered over it, and then we can see a cross section of our CBCT DICOM data. So our plan here, for those of you who don't or aren't familiar with the socket shield or root membrane approach, is to basically leave a small thin piece of the buccal part of this root in place intact so that it can preserve the blood supply to the buccal plate, tricking the bone to think that the root is still there, so that we can keep this nice prominent contour of that the canines usually have, so that when we restore it, you have a very natural looking aesthetic crown. So based on this, what we just did is I sort of decided where my crown's going to be. I made sure that my axis is, through the cingulum, so we get a screw retained crown. And then based on this, we decided on our ideal implant position. So if you look closely, you can see in the pink an overlay of the actual implant position with respect to where the existing root is. So you can see here is our root in the purple. There's our simulated virtual crown, and then the ideal implant placement. So now looking at this, the goal here is to leave a very small layer of root on the buccal. And the good thing is you can see based on where our implant position is, we're far away from the actual root shield or root, the socket shield or piece of the root. So there's no risk of any touching. So virtually I've segmented what I wanted as the root shield. And so you can see it there in green. And what we do is when we take out the root, so this allows visualization. So there's our little root shield. There's our implant. So this is what's going to be there in the end. So based on all this virtual planning, I have an idea now of how much and what angle I'm going to go in and trim the root. And I know the shape and everything. And these are just two-dimensional images that you guys are seeing, but what I have on the computer when I'm planning this is I can turn this in multiple areas. I can flip it over, look at the backside so that I know. So I'm basically turning it around and looking at it in all angles so that when I'm going in to place my implant and to trim that shield, I know which way and how I want to trim it. And so here's the case. This is a special kit from Brasseler. It's actually, I think it's Maurice Salama's PET, so partial extraction therapy kit. And these are all the burrs that we use. They're made a lot longer. They have a long shank, so that allows you to do this root trimming. This is a special tip that sort of protects the gingiva and allows you to trim the coronal portion of the root shield. So here's, once I've made my root shield, you can see the portion of the root is removed, and then the rest of it is sort of thinned out and slightly adjusted to make sure that you're actually leaving enough prosthetic space and enough space away from the actual implant. Okay, this is the portion of what's removed from the root, and there we go. That's our root shield up close. Here's our implant in place, so you can see there's a nice gap that we can add bone between our implant and our root shield. I usually then just put the carrier for the implant in place while I pack the bone in. I usually will then just pack the bone all the way to the gingival margin, just sort of, as much as I can to just fill in that space. And then to make this, one step further, I want to keep this contour that you see there, and I want to keep the shape of the gum. So what we did was, from here, now that everything is packed in and the bone graft is in place, we created a customized healing abutment. Now this customized healing abutment is just made with flowable resin. It's made chair side. And what this does is it captures the exact shape and profile of the root. And so literally the whole procedure, you can see everything is done internally through the same socket. And once it's done, there's no stitches. This patient leaves barely feeling any discomfort or pain. They come back, they're so happy. They're like, that was like nothing. So part of that planning allows a little bit more precision and accuracy, allowing you to keep things a little bit less invasive, because you already know what's underneath without having to actually open it, because you have the virtual plan. They come back 2 weeks later, and this is how the tissues heal. So you can see the profile, that prominence is kept in, the tissue look nice and healthy. You can see now there's the nice thick pink tissue. You can see stippling in there, and this is what we like to see. And the best part is when we take off the healing abutment, look at that profile. Look at how we shape that gingiva. Look at the buccal contour of this tooth. Now, this maintenance of this buccal contour, it's not possible unless you do a socket shield approach, because this prominence will mostly definitely always remodel if you take out the whole root. By keeping that small root membrane, you're tricking the bone and thinking that the tooth is still there, so it maintains that contour. So you see now, when we go ahead and we restore this tooth, it's going to look very, very natural. If you look at it here, you can't even tell that there's an implant crown. People probably just think it's a restorative crown. And when you look at it from the other side, you can see that buccal contour. Look how nice and shaped that is. So this is what we want to do, and it's possible because of the fact that we sort of were able to preserve everything. We're thinking biologically, tricking the body using the partial extraction therapy, and then maintaining that soft tissue profile with the customized healing abutment. So all of these steps come into play when we're trying to make a nice, clean, aesthetic result. So a lot of this, or the work of this, or the precision of this case, comes from all that digital planning. So we'll go over a few other cases now. Just I'll sort of touch on a few different types of cases, just to show different variations of how we can use digital planning. So this case, this lady here, the tooth actually is just a crown that's actually bonded in place. She actually had the tooth luxated and it avulsed actually, and it was just bonded in place without the root. And she was brought to see me. We sent her, to augment the site, and they wanted to know if we could at least do an immediate implant. Unfortunately, off of the CT scan and a digital plan, you can't see it in this model, but basically the tip of the root goes almost to the floor of the nose. So there's literally no bone to even engage the immediate implant. With this, even though there's a lot of buccal bone loss, you can still do an immediate implant because of the fact that the defects is maintained within the alveolus. So this is what we call an internal defect. It's within the alveolar bone. It's just really just missing the buccal plate, but the walls are there. So this is a very predictable and easy way to regenerate bone, even though when you look at it, it looks like quite a large defect. So when we look at this, I can virtually even just extract the teeth out so that I can see the defect a lot closer at different angles. And here you can see the size and shape of the defect. Again, you can see from the occlusal view that this is mainly an internal defect. Regeneration of this is quite easy and quite predictable. So what we did is we even virtually placed an implant. And again, because of the lack of buccal bone and the minimum amount of bone apical to the point where we're in the floor of the nose, we had to use a staged approach. So deciding on my approach, now this is where the digital bone graft comes in. So looking at this case, this is a defect, and I thought, okay, what's, for visualization's sake, let's put a bone graft in there. So here is my virtual bone volume. Okay, we put in the bone graft in there digitally, and then what we do is, this is the bone we'd like there. I sort of then fill this, and then I sort of remove that volume out, and we see what it is. So you can see from, this is just different views of the same graft. we can see the volume of the bone. Majority of that volume is just internal. It's the internal filling of the socket, and there's a little bit on the buccal. So again, this is something, looking at this and looking at this virtual model is something that I can easily do just through guided bone regeneration, like and using just particulate bone and a resorbable collagen membrane, and we should easily get the volume that we need to complete our goals. Okay, so this is what I meant by looking at the virtual volume and looking at the bone graft and deciding now what's the easiest and simplest way to get the bone that you need. And then using that data and that information, this is the actual surgery. Okay, so virtually I've already kind of decided which way I want to go. You can see once we open the flap, this is, what's there. And so in this case, I already knew the defect and what it looked like virtually before I even opened the flap. So that's why you see here, I didn't try to just pull the root and try to work within that opening. I knew it was a larger defect. I wanted access to be able to put particulate bone and cover it properly. So we decided ahead of time, because we had all that digital information, that we're just going to go ahead and open the flap. We open the flap. I over contoured the bone particulate because we do get a little bit of resorption as it remodels. I sutured the membrane in place. This is just a fancier version of one of my periosteal tacking sutures to hold the membrane in. And you can see the contour. We've added a little bit more extra particulate bone to bulk up the contour because of the fact that we will get remodeling during healing. And basically then that same tooth is just splinted back in place with resin, and she leaves the chair like this. Now this case should be actually coming to see us soon for the implant, now that we're back open and the pandemic is slowing down. But again, this is to show how we virtually designed and planned the case so that it made the actual surgery much easier without too many questions. Again, this is a key point where sometimes, you'll go in and pull out a tooth and then you'll realize there's no buccal plate, and then you'll sort of work backwards and be like, oh no, I need to open a flap. Some people then make these little mini papilla sparing incisions, or they make an incision in the vestibule. So you're sort of trying to back up and then compensate for your new findings. Whereas our digital approach, we already knew what was there underneath, and our path was clear. We knew that we were going to go ahead. I knew I was going to open a flap, and so there's no questions, there's no backpedaling. It's just, this is the way it is, we're going to do it, and we go. So again, it just makes your workflow and your procedure a lot faster and smoother, because you know where you're going, you have that map already. Another case, now this is the same thing. We're going to show how I digitally do the surgical design. This will take it a little step further. In this case, we're going to show you how we actually looked at the defect. This is a different defect, so it's going to be grafted in a different way. So here's our case. We look at our clinical pictures. Usually the clinical pictures are used for soft tissue evaluation, the CT scan data. Okay, here we have our virtual implant and crown place, so we see where we're deficient. So, and then there's our intraoral scan. Intraoral scan, usually I take a look at tissue volume, because sometimes you may have adequate bone for an implant, but then when you look at the tissue volume, it still looks like it's lacking contour. So cases like those, we may choose to only go ahead and proceed with a tissue graft and not a bone graft. Okay, and then we sort of bring all this together with the bone. Here's our bone defect. So this is obviously a much different defect than the previous one, because this one looks like the tooth was missing or extracted a long time ago. So the jaw has remodeled. Now this is not as much of an internal defect like the previous one, because the walls of bone are much thinner. So here's our digital crown, okay, and layered over the bone model and the intraoral scan. From this data, we've obviously put our implant based on where our crown is going to be, and looking at this now, we see where we're deficient. Okay, now based on this, I can see where I'm lacking bone, and where I'm where I have bone and where I need it, and this allows me to basically plan what type of bone grafting procedure would allow me to gain the volume that I need. So remember, first step we do is decide on what volume we need. And so here you go. Here's our digital bone graft. Here we can see the bone volume that we have, okay, and the bone volume that we need. And now from this, what I do is I take out that bone volume or that digital bone graft, we pull it out of the model and we look at it in its own free form. Again, because remember this is on a computer and you guys are just looking at a two-dimensional lecture, I can move this around. So I've shown it to you in different angles so that you can see where the volume is and where we need. So one thing to note is that I noted in this specific case is that we need a little bit of volume on the crest, we need some volume palatally, and we need some volume buccally. Now, in order to be able to reconstruct this defect, I have two choices now. Well, three actually. So one is we can do some block grafting, which will gain us the vertical and the augmentation that we need. Two is if we use a guided bone regeneration approach, probably we would need some sort of space maintenance. If we're using a non-resorbable membrane, then it'd have to be titanium reinforced. If we're using a resorbable membrane, then we'd probably likely need some tenting screws to be able to tent the space so that we can get adequate vertical height and volume on the pallet as well. And then we would likely have to tack or pin the membrane down to support the bone graft so that there's no movement. And then thirdly, as an alternative to autogenous bone, you can use allograft blocks. Now, in this case, the patient wanted the treatment faster. And so I had originally offered autogenous bone blocks because it remodels the fastest, and usually within 4 months or so we can place the implant. But he didn't want us to go to the jawbone. So as an alternative, I said, okay, I can use allograft blocks. It takes a little bit longer, but we'll mix it with your own autogenous bone. We'll use growth factors from his blood, PRP and PRF, and we'll sort of combine it all together, and we should get the results we need with the timeline that's acceptable to you. So what did I do? We first designed our bone plates. So now that I know the amount of bone that I need, I can create the bone plates that I would require for this defect. So virtually we recreated the 3 bone plates that I would need. And remember, this is going to be allograft bone, so I can literally trim and adjust the allograft blocks to suit the size of my surgical site. The bone plates are here virtually shown, both on the buccal, on the palate. So we have 1 palatal bone plate and 2 buccal ones. And you can see how they're positioned to make sure that we maintain our vertical height. And so these bone plates will act to be space maintainers, to hold that space and that volume to allow the bone to regenerate. This is just showing the bone plates in the CT software, so you can see it aligned and you can see it in different cross sections with the implant, ideally our planned implant position. And you can see that if we get the bone within these preset dimensions, we should be good for our future planned implant site, and we should have adequate bone volume and everything should turn out nicely. So to take this a step further, we can print a 3D printed model. Okay, here we actually put the actual implant in there so that we can see it. Here's the implant. You can see in this case it's sticking out because these are the pre-op bone dimensions. And then with our virtual plan, I also printed out the little bone plates. And the reason why I printed it out is so that you can sort of use them on the model as a mock-up of where you want them and the shape they're going to be, as well as to help me when I actually take my bone block, I can use them as an aid to shape my little bone blocks from the allograft block. So here's our allograft block. And here's our surgical table with the model. Okay, these are usually cold sterilized because they can change their dimensions if they're put in a sterilizer. So we sterilize it with ethanol and alcohol and isopropyl alcohol. And basically they're just used as a guide to help manage and shape our bone. So here's the allograft block with the printed 3D plates. And then these are used, and basically those plates are then used as a guide to trim the actual allograft bone, and it allows, again, a lot simpler surgery. So here's our actual surgery. You can see we basically did a combination of a mixture. We mixed autogenous bone scrapings with particulate allograft with the PRF and sticky bone. The bone blocks were positioned in their planned positions from the 3D virtual plan. Once the bone blocks were positioned, the gaps in the space within the blocks, or that space that they're maintaining, were grafted with our particulate bone. covered with our collagen membrane. Now this is an allograft block. I usually cover allograft blocks with collagen membranes. If there was autogenous bone, you don't always need to cover with a membrane because autogenous bone just reacts differently with the periosteum. And then you can see after a few months uncover, you can see we got adequate bone volume, and then we're just in the provisional phase. I think he should be almost restored by now. But now to take this one step further, when we're doing the final crown of the provisional, you can also use the facial scan because this is an anterior case. You can use a facial scan here to look at the crown shape and the positioning and the implant placement. So this can be used when you're planning your implant placement. And you can get an idea. So this is more just for visualization, but it helps you and the patient see what the tooth and the shape and the color looks like when they're looking at their facial scan and they're smiling. Okay, and that's where the facial scan comes into play and why it becomes benefit. And you can see in layers how we can go into the tooth. We can see the implant placement. You can pre-choose your abutment height and things like that. And so this is what we started off with our bone augmentation, and this is what we finished off with. So you can see now adequate volume palatally and buccally. Now we can put our implant in the pre-plant position without any problems. Okay, so this is again the concept of that virtual digital planning. Now in this next case, we're going to take it a step further now. In this case, as opposed to using allograft bone blocks, we're going to actually use the patient's own bone. So in this case, the patient actually had a traumatic extraction. When the dentist had removed the tooth, they realized that there was a big bone defect and lack of a buccal plate. So we let it heal for a few weeks, and he said, you know what, you're going to have to go see the specialist to have him just augment the site before implant placement. So when she came in, she had just had the tooth removed, and this is what she looked like. Now, what we did was we took a scan, and basically she had large lingual tori. And so she had made a comment of them sometimes getting uncomfortable when she's eating and they're bothering her. So what we ended up doing is she wanted us to remove them. So I thought, okay, if I'm going to be removing these, at the same time, we can do your surgery and I can use that same bone to augment your site. We can basically, since you're missing a buccal plate, I can recreate that buccal plate with your tori bone or your torus bone. So we looked at the CT scan. You can see the large tori on bilaterally. Okay, here, if you look at the defect, again, you can see the tori and then basically a larger defect, which looks like an extraction socket with no buccal plate, which is literally what it is. Okay, so through our digital segmentation, this is her bone model. So you can see literally it's a socket with no buccal plate. And if you look at it coronally, you can see the tori. So the plan was to take the tori and cut it in multiple slices to reconstruct some bone plates to allow us to reconstruct that bone loss in that socket. So what we do first, again, we put our virtual crown in, place our virtual implant, and then we look at our defect. Okay, so here we looked at the tori on the same side as the defect, and I thought, okay, well, this, you can see it shaded in blue off of the actual original mandible. So what we do is we sort of make our cuts in this tori, and I could segment and remove this portion of the tori out. And then now that I know that if I surgically can cut this part and keep this part, I can use this to create and harvest bone. So what we do is from this tori, we take that one piece, I virtually create some osteotomies, I cut it in half, and then I cut that one piece into two plates. Now these two plates now can be used to create the bony walls. Our plan is to put one on the buccal and one coronally to cap the site. And then what's left, we usually will mix and crush in a bone mill to fill in the internal part of the socket. So based on the planning in my virtual surgery, this is what I came up with. Okay, using those two plates, we're going to have one coronally, one buccally. And because of the way it wedges in on the top, I only thought I needed one screw. We could have planned to put two if needed, but this is cortical bone from the tori. It's really hard to drill through. So I think because of the way it wedged in, one screw was adequate enough. And between the two plates and the existing dip, it wasn't moving at all. So one screw was good enough for the coronal portion. On the bottom buccal plate, we ended up putting two. So through my virtual plan, we start off with our original bone model, planned our crown implant. We virtually did our osteotomies to remove the tori, decided on a computer how I'm going to cut the tori into slices and plan to do the bone graft. So here I already have done my surgery. So this is my virtual surgery. I basically planned and done all my osteotomies, and I know exactly what size and shape I need to reconstruct this defect. So from now, what we do is we take this digital plan and I print my 3D models. So we have our jaw model here with our defect, and then here's our different sections. So you can see the tori in the original jaw model at the top in the clear, and then the segmented initial tori, which is this brownish pinkish color, and then we have the yellow one, which is the cut in half, and then that yellow one gets sliced into 2 pieces to make the 2 little green and blue ones. Okay, so virtually we have originally that virtual torus that was originally cut out and then cut in half to make this piece, and then the 2 piece. So here, this is our virtual models, and these are our actual 3D printed models. Now, these are just used as aids, you know, when I'm shaping and trimming and doing the actual surgery. So here you have our 2 pieces, and this is our plan. This is what we want to do. So we want to take those pieces, and that's the way we're going to do our surgery. And so now when it comes to the day of the surgery, I literally know exactly how I'm going to cut that tori. There's no thinking or guessing. I basically open the flap, we cut in 1 piece. I know I don't even have to measure in the mouth again. I just cut 1 piece, I cut the other, I slice them again. I'm using the pieces of the 3D printed model to shape it and adjust it, and literally once they're done and they're ready, I can just take them into the mouth and site. So here's the actual surgery itself. You can see basically we're taking the pieces of bone, we're slicing them, crushing it, putting it in the way we've planned. The site is closed, and 4 months later we have the ridge regenerated. Okay, and this was done and easily done for 2 reasons. Like looking at this defect, you wouldn't always need to use bone plates, but because of the fact that we're already removing her tori, I thought, why waste it when we can do something cool? And so all of this, again, was all virtually planned. And so this digital surgical design allows me to know, again, where I'm going, makes my surgery a lot less, you know, lots less guesswork, because again, the exact osteotomies, where I'm going to cut, how I'm going to cut and shape is all pre-planned virtually, so that I don't even have to think. It's literally like, here's the recipe, just follow it, you're good, and you're done. Okay, so that's taking, now we're going to take it another step further. So now we're going to say, okay, so that was virtually planning the surgery. Now, how could I have a little bit more control? And so what we do in this next case is we're going to actually harvest a bone block from the chin, but we are going to plan our bone plates ahead of time and then harvest a block that is going to be the exact shape of those plates. And we're going to use a surgical guide to have this done, so that there's the least amount of error and we can get a little bit more accuracy. So this is a case. Here's our case. Okay. So here's our plan. You can see we've reconstructed the plates that we need. This is the CT slices of the actual symphysis. So we've planned where we're going to get them in the chin. And then this is our 3D printed guide, which has the blocks. Now what we've done is, if you look, there's a middle raised portion in the model, in the actual guide. So those are, that raised bump in the middle of the guide where the window is to tell me where I need to make my vertical cuts so that I can get the pieces with the right amount of accuracy. Now here you can see there's a lot of space in blue of the original bone, and this is because I'll be cutting this with the piezo, so we wanted to compensate for the actual cuts of our drill or our piezo. So we actually left a little bit of space so that by the time we actually cut through this, we are not going to lose any of our volume of our actual block. So we've compensated for that by leaving this space there. Okay, so that's a key thing to remember sometimes, especially if you want to be really accurate. So this is our initial defect. This is just our virtual implant plan and our prosthetic plan. This is our virtual surgery when we've decided on the bone blocks and the positions, and those bone blocks now are basically harvested directly from the symphysis in our planned approach. So now we're harvesting the exact sizes that we need, not by guesswork, but by using a surgical guide. Okay. And so using that data, we have our 3D printed model. So here's our 3D printed model. And you can see the notches in the guide, which tells me where I need to make my vertical cut so that now I'll have 3 squares or 3 pieces. And now because of all that virtual planning, the surgery is much more easier, less guesswork. So here's the surgery itself. So flap is open. You can see the surgical guide in place. All my bone harvesting guides are tooth-borne, meaning that they rest on teeth. It's the only way I can ensure that it's accurately positioned. Because if you make a bone supported guide, there's always more error because you can never segment the bone as accurately as you can scan teeth. And so I try to make all my guides be tooth-borne if possible because it's a lot more accurate. And so you can see here, the cuts are made with the piezo surgery device, a piezo saw. We remove the 3 pieces, we harvest some autogenous bone scrapings, and that's used to just sort of pack around the blocks. The blocks are then screwed into place based on our virtual plan. And then we added a little bit more particulate all over everything. In this case, I actually covered it with a collagen membrane because I added a little bit more particulate for contour, but you don't really need to. So here is our virtual plan, and this was our actual surgery. So you can see everything sort of matches and flows based on our plan. And then we wait a few months, and this is what we find out. This is autogenous bone. So you don't see bone like this in a few months unless it's autogenous bone. So here's our implant plan. It was a guided implant placement. Here's our 3D printed guide for our implant placement. And once we uncovered, this is our site. So you can see this is the bone. So you can see there's hardly any resorption. Look at where the screw heads are. This is nice and solid bone. You can see the pieces, the plates have been fused together really nicely. You can see even as I unscrew the screws, you can see how nice the union is between the plates. And this one, I love this picture. You can see how nice and thick that bone is. So, and how nicely remodeled it is. You know, it just looks like a solid block of bone. So this is what you get from autogenous bone. And, you know, this is why they call this the gold standard. There's nothing that grows bone like autogenous bone. You still get good results from other areas, but the quality and in the amount of time, nothing competes with autogenous bone. So this is just our implant placement. You can see there's our implant osteotomy. Implants in the planned position. Here in this case, if it's an anterior case, we did a pedicle connective tissue graft and close it up. And then what we do is we give it time, and then once the implant's integrated, I'll give it a few weeks, and then I'll uncover it and start the provisional phase. So, but for the point of this lecture, I want you to focus on all the digital planning that was done to be able to have that augmentation surgery flow smoothly. Now here's another case, same concept. This is just we're going to be using a ramus or an external oblique ridge harvesting block graft. Okay, so here's our block harvesting guide. Again, this is designed. Notice how it's resting on the teeth, and this is because I can maintain accuracy, especially if I'm close and around the nerve. I want to make sure that there's no discrepancy in how that guide seats, because I want to be as accurate as possible. And so again, I make them all tooth-borne, okay? I make it a longer span because it's easier to hold and seat down. If it's a shorter span and doesn't go on as many teeth, it'll start to rock. Here's our 3D printed guide and the jawbone model. And basically, because everything was virtually planned, this is the guide in place. You can see here, guide in place. We use it to make our cuts. The block is easily removed. Here we use the Curie approach. So we sort of displace the blocks a few millimeters away from the ridge, and the site in the gap is grafted, covered up, and closed up. And then you can see in the last image, it's the re-entry after a couple of months. And you can see the bone, how the bone is remodeled. And this is the before and after. So you can see how much bone volume we've gained. And usually at this point, then we can, you know, I usually add a little bit more particulate just to fill up the contours and the shape, and then we put some healing abutments or customized provisionals to start to shape the tissues. Okay, but again, the point of how we had that bone block guide and how it's tooth-borne and how it was all pre-planned so that you can easily harvest a bone block without any worries or risk of being close to the nerve or having that fear. Okay, so it takes the guesswork out of it. Here's another case. This one is also another bone block case. This one I can show you that with these guides, you can be, you know, more inventive and creative. So in this case, I needed multiple blocks. So what I did was the patient actually had a small edentulous space in the teeth. So we actually made a double block harvesting guide. So here we have one where we're taking a little bit further back where the ascending the ramus is starting, and then the external oblique ridge, and then an edentulous space there. So I was actually going to get, the plan here was to use 4 blocks. So I was going to take 2 bigger blocks and then use a diamond saw and cut them in half to get 4 pieces so that we can reconstruct that anterior defect. So this is our 3D printed jaw model as well as the actual harvesting guide. Again, this is tooth borne, so this is the guide in place. You can see how it fits and seats nicely in place. We use the guide in place to make my osteotomies and cuts. Okay, this is just showing the cuts before, and then we remove the pieces of bone, and this is just showing how clean and accurate it is and how it follows the guide. We're just showing how the cut, and then this is just the defect after the blocks are made. Now these defects I usually fill with particulate bone, and just to fill back the contour. And then basically those 2 blocks were then sliced in half with the diamond saw to give us these 4 blocks. And now this is what I use to reconstruct the case. I don't have the pictures here, but those blocks were then also 3D planned in a specific position in this site. And so we again used a similar Curie approach where we put the blocks in, leaving a space or a gap. And then the 2 smaller blocks were screwed on the top just to fill in the coronal portion. The internal portions were filled with a particulate mixed with autogenous bone, and then we just added a little bit of particulate over the whole thing and closed it up. Okay, so this is the site closed up. We gave it about 5 months, and then in 5 months we uncovered the site, and this is what we found. So again, you can see where all the screw heads are, very little resorption of the bone. We have a nice thick remodeled amount of bone. You don't really see any particulates. It looks nice and clean. Here's the 2 implants in place. They were also guided in place. This was a guided implant surgery. I always try if I can to do a guided implant surgery if it's more than a single unit, because it's just more accurate and, you know, it's less guesswork. And we have the technology, so why not use it? And so here's just, I'm showing this before and after so you can see the amount of bone volume that was gained from these procedures. And again, all this was all virtually and digitally planned. So it makes it quite easy. It takes the guesswork out. You know, this is really good for people, you know, who aren't as comfortable with harvesting blocks and they just need that extra guidance and just to feel comfortable and give them a little bit of courage. Digital planning sort of makes it a lot easier. Okay, not to say that it's a solution, but it does make it easier. And remember, anything digital, there's always times where you have to use your own brain at some point. You know, things sometimes don't work. So if you don't know how to do it without a guide, make sure you learn without a guide first before you go to guides, because you can't control technology all the time. So this last case, now this is not a bone augmentation case per se, but I'm going to just show you this because I want to show you where technology is going. We did this actually a few years ago, but I'm just showing it again because when we did it, the planning was really hard. It was really tough to work with this technology, so it wasn't as user-friendly. So we never really did any more cases because it was hard to work with. But it's really cool that it showcases our likely future, because this will take you to the next step. Because right now, you know, we're printing 3D models. I think with this technology, there'll be no need for printing. The other cool thing that we're actually working on right now, I was supposed to do a few cases, but the pandemic shut us down. But you know, maybe at some point in the future you'll see some more cool stuff. Is the guides themselves give us a way to cut, but we're not seeing internally. And so what we're now incorporating is the Navident system. So we're using guided navigation so that I can see my piezo saw cutting in real time into the bone on the CT scan cross section. So we're going to incorporate navigated bone block harvest soon, once I get those patients back in and we can start filming some of these cases. So a lot of cool things coming out in the future. So I'm going to show you this case. This was actually, it was a cyst that was formed. What they found was there's a small, either a supernumerary tooth or some sort of retained root fragment that had initiated this cystic lesion. And so what we did was, you know, it was quite a large lesion, and this was a young girl. She was, I think, I think in her late teens, or like 18 or 19. So we didn't want to make the surgery too traumatic. And so what we did was, using that digital information, we created a 3D printed model. Here you can see different sides. So we can see so this is the palatal view. I can see an opening into the palate from the lesion. So, but it was really high in the arch of the vault. So, for me to access this from a palatal portion was really tough. So what we did was, we looked at the jaw model, and we thought, okay, you know what, I'm gonna use this technology. I'm gonna use the 3D planning, and it's hard for me to work and get good access to remove all the lining from the palate. So we're gonna go on the buccal instead, and I'm gonna cut a bony window or a bone plate. Okay, so here is just to show you the palatal access. So you can see how it's going to be tough for me to go in and make sure that all of it is cleaned, unless I reflect the entire palatal flap, which is more uncomfortable. So what we did is, we went through the buccal. I used a piezo saw to cut a nice buccal window into a pre-planned site that we had based on the 3D printed model and the virtual planning. And I kept that bony window. So we basically kept the bony window. We just removed the cortical plate. You can see the lining of the cyst there. So everything was cleaned out and nucleated. Okay, once it was all cleaned, we then packed some bone graft material into the site, and then put that bony window back in place, and we sutured and closed it back together. And then we also removed the cause of this cyst. And here you can see that it looks like it's a supernumerary or weird malformed root that initiated this lesion. So good thing we were able to find it, remove all the lining, and everything healed up fine. Now, some of what we did for this planning is what I'm going to show you in the next video. And this is where I think technology is going to really revolutionize surgery. Okay, so this is, I'm going to show you a short video of, maybe some of you guys have seen this before because I have posted it on some of my social media, but this is augmented reality in surgery. So here's our jaw model. Okay, the music is not playing really nicely, so ignore it. It's not supposed to sound like that. But here you can see the model itself, okay? And it's in real time in my surgical table. And you can actually move it in and around your operatory. And then you can resize it however you need to, just so that you can see it visually. And then the cool thing is, we can also bring the CT scan data. So the CT scan report can be brought up as tiles, so that you can visualize those while you're working as well. So we actually had a HoloLens worn to simulate this, but it was very difficult to do. And there's a lot of planning, so it's not convenient yet. And it's not, the workflow is too complicated and too hard. So we never did it again, but this is one of those, we tried it once, we did it, and that's it, I'm done. I move on to the next until it becomes easier. Okay. So that's it, guys. So I have another special announcement that we make. Usually I would, when we do some of these cases, I get a lot of people that have asked, whether I teach and do stuff, and I do teach sometimes through live courses, but now with the pandemic and the world changing, we, Stephen Phelan and I got together and we thought, let's take this online. And so we'd like to introduce our GBR online program. We introduced this program about a month ago, and we sort of opened it up just because it was our charter membership. It was the initial first time launch. So we opened it up for about 4 days, let a bunch of people join, and then we closed it up. And what it is basically is the way I do bone grafting. So it's sort of an introduction of how to do bone grafting and how to use the techniques and methods that I use in my practice. And it starts with the basics and the fundamentals, and then throughout the year we go on. So let me talk to you about a little bit about it. So, if you ever had a big vision about your future, your practice, you want to do more surgical procedures in your practice, you want to expand the scope of your practice, you want to expand your existing surgical skills, or maybe you do surgeries, but you either just weren't taught the right way, or you just want to get a refresher course. This is the course for you. It's designed specifically for someone who is either a beginner who doesn't know anything, or someone who's done some work but wants to sort of refresh their mind and maybe see a different way of doing things. We have numerous members already. Some of them are in academics, and all of them learn something. Even me myself, experienced surgeon, I'm learning stuff just making the content again, because sometimes it's a refresher for me to go over the basics. So it's not only, so the program itself is combined of a set of 6 modules, but it's also a coaching program. So we've designed it as a way to teach dentists and other surgeons systems that allow them to manage basic augmentation to even more complex augmentation cases as we go along. It's an online curriculum, so it's all taught online. So we have customers or doctors with us in our group from all over the world, Mongolia, Suriname, like Europe, Australia. So everyone has access. And basically, we focus, the main modules of the course focus on fundamentals and give you a good foundation to start your journey and allow you to tackle more complex cases. Okay, if you are placing implants, this course is a must. I think anyone who's placing implants should know how to do some bone grafting. And so there's been a link that's going to be added to the side of your page if you'd like to join or learn more about it and sign up. Okay, here's that link here. Okay, but it'll be on the side of your page in your meeting, and it'll come up again if anyone's interested in looking into it and seeing what it's more about. This is our actual web page, or from the page, and you can see some of the modules that we have. And the way the course is designed is, like I said, it's got 6 modules. Okay, the first module is an introduction to GBR, the concepts, as well as biomaterials. You learn the fundamentals of bone grafting materials and membranes, and understanding what's the difference between all of them. Here's some of the modules and the pages from the site. You can see a lot of content for each module. Okay, and then there's module 2, which goes over anatomy for bone grafting, what you need to know, what you need to watch out for. And then we go into defect site analysis and treatment planning, and how I decide to do it. A lot of the digital work is in this module. Here's again some of the pages of the module. Some pictures do look similar because some of the slides that I've shown are from the course itself. And we will show you actually how to do the digital bone grafting and planning in part of this course, so you can create your virtual digital bone graft and help you start to plan your cases. Module 3 is instrumentation, incision design, and flap management. This is, tells you the surgical kits that I use and the basic instruments and kits that I use to do the procedures. We talk about, how to design your flaps and how to release and control the flaps for ideal management. Here's some of the videos in that section too. We use, pig mandibles, there's clinical cases, and, videos to help teach the concept so that you understand it from the basics. Usually a lot of courses don't spend so much time in some of these details, which are lost, and it's one of those key things that you got to have a good foundation to be able to expand your skills. Module 4, actually we're in the process of still running this. The module 4 actually is on Monday night is module 4. We do a live webinar. So the way the modules are released are, there's a live webinar. This will be talking about bone grafting materials, how to prepare them and place them, go over how to tack and pin and suture membranes, how to make sticky bone and PRF membranes and gel membranes and things like that, how to harvest autogenous bone. So all this so that you can use, and how to secure it into your surgical sites as part of module 4. And then coming up, module 5 goes over suturing to close the site, postoperative care, and complications. And then we have the final module, module 6, which is usually goes over guided bone regeneration with implant placement. So we talk about, sometimes when you place an implant and you have to do bone grafting at the same time, and we'll go over different scenarios and cases. Now, the program itself sort of deconstructs bone augmentation to focus on each detail of the procedure, and we sort of emphasize all these technical details that sometimes are overseen or skimmed over in other courses. Okay, it's a different approach because what we do is we also, each of the live webinars, we have an interactive component where some of the doctors will come online and discuss some of their cases that they submit prior to it. It's also, part of it is not just the 6 modules. When you join, after the 6 modules are done, there's a monthly webinar. We have a private Facebook group. So all of these help with the interaction and the online coaching. We go over multiple cases, and all throughout the year now, once we do the core of the webinars and the core modules, we'll start with live surgery. So now that we're starting to work, I've already started to record some of the augmentation cases that I do just daily in my office, and these will be shown and discussed and broken down in the monthly webinars. So you'll get to see actual live cases and live surgery and see them sort of evolve as we go along. And I work with Stephen Phelan as well together. He's one of my referring doctors. So with his, if you are an occlusal design member, you might sometimes see combined cases where you'll see the surgical part by me, and then you'll see the restorative part by him. So you get to see both aspects of the same case done together, which is cool if you're part of occlusal design. So what types of cases, what can you learn from this? This is some of the cases that you learn, cases that, you should be able to easily take care of once you've done the course. Here's a horizontal bone augmentation case, an anterior area, we discussed, it's very easy to, by the time you're done the course, you'll know how to secure and suture the membrane in place. You'll know how to release and close your flaps, adjust the tissues and get a result like this, because this is quite easy. Once you know the basics and the fundamentals, this is a no-brainer. Okay, here's the implant placement and the suturing. And so all of these stages, of this case are all shown. And this is something that you easily will be able to do in your office. Okay, so it may look challenging here, but once you take the course, something like this will be a breeze. Okay, and this is the same case, just continued to completion. So some of them, if we finish and we have the case and we work together, you'll get to see the entire case till the end. And so this is the finished case, and this is just the before and after of the bone augmentation. So again, cases like this, you should easily be able to take control of and keep in your practice so that you can be able to do this. Here's another case that, again, this should be fairly simple for you to take on. It's a horizontal augmentation. It looks like it's a severe defect, but once you understand the principles and understanding a bone defect, you'll know that it's not as challenging as you think. In this case, we used particulate or resorbable membrane, but the membrane was, instead of sutures, we secured it with bone tacks and bone pins. Okay, close it up, let it cook for about 5-6 months, and you open up, and this is the bone you regenerate. See, and now we have adequate bone for our implants. And again, to stress that this is something that's not going to be challenging at all. By the time you've had a year with me, something like this is going to be very, very easy. And this is the whole case again. So again, understanding the basics, but then also learning how to use digital technology. And then you'll get to see sort of whatever I do in my practice throughout the year, through the monthly webinars. We go over, we discuss. The Facebook group itself is a place where you can sort of post your own cases, ask questions. I'll answer, we can treatment plan, we can go over any complications or issues you have. So there's always interaction. So that's what makes the value, I think, of this course, is the fact that you get this sort of online mentorship and coaching, and you get that continuous interaction. And that's where I think the real value is, because once the modules are done, you have that knowledge, but then you continuously get new cases, new knowledge monthly. I'll start to post live cases on the Facebook group, as well as save them for our monthly webinar. So you'll always be seeing cases. As long as I'm working, you'll see new cases. So the content just keeps coming and coming and coming. Okay, so again, if it's something that you're interested in, today, actually, as a special for those who join today, we're going to actually do a live session on our Facebook groups at Facebook Live, where I'm going to be showing some flap management and flap release of buccal and lingual flaps on a pig mandible. So again, here's the website, phelandentalseminars.com/gbr-online-digital. Okay, so now I'm gonna let Dr. Phelan do a little bit of talking. We've been building this course, and he's on the other side of this. He's like a student like you guys, so he's gonna tell you what he thinks about the course and talk about other things about, if you guys are interested in signing up. Okay, so Steve, you can take over.
Hello, hello. I'm just switching to my screen. Show my screen. There we go. Thanks, Nahid. That was really cool. Oh, I'm just
Do you
sending
want to do
you.
questions first, or?
No, I'll go through the rest of this part of the presentation, then we'll do questions.
Okay.
That's what we'll do. So just to let everybody know, everybody who's a GBR online member, when you register, you get on the next page the link to join our Facebook group. When you join the Facebook group, today, after this webinar, we're going to have a live stream demo, and Nahid's going to demonstrate flap releasing techniques, but he's also going to demonstrate suturing techniques, so to close that flap. So likely some mattress suturing and continuous locking suturing type of techniques will be shown. And then, I look at difficulties with doing cases like this. I've done a lot of this over the last 10 years. Um, about 12 years ago, I started doing guided implant surgery, and a lot of cases can use GBR techniques, either to get the case ready for the guided implant surgery or simultaneously during the guided implant surgery. And some of the small details about doing these things are the things that Nahid is going into in very precise detail during the program. One of which is just different releasing techniques for flaps and flap contour and design, incision designs for flaps. There's a lot of small details that he's going into in the modules that will help you with your surgeries. And I can attest that doing a video based online program, you can learn to do procedures in the mouth, because I've learned just from taking this course and other courses over the years. So I don't believe that you need a specific hands-on course with Nahid sitting there watching you. I think that it can be done with a video-based online course. And we have some good ideas about making this almost a hybrid course, which we'll talk about in a little bit. So everybody that joins today will be invited to this live stream, which will be going on in a few minutes. And we did this last time, and it was really cool. The people enjoyed watching the live stream. Nahid's using a Epson document camera to show exactly what he's doing close up. You could ask questions. It's going to be really interactive and fun. And let me just point out that this is not a website with a random collection of videos, the GBR online program. It's a comprehensive curriculum designed to teach you how to manage simple to more complex bone grafting cases. And by comprehensive curriculum, again, it's module 1 to 6, detailed minutia of doing this, meaning incision design, flap releasing techniques, membrane suturing techniques, membrane tacking techniques, just different membranes and the science behind the membranes. There's a significant amount of detail here. Module 2 on digital anatomy and digital planning is 7 videos in itself. 7 videos about digital planning, working with the DICOM files, going into the different softwares and designing the digital bone graft, etc. It's very, very detailed. So, the other thing is that Nahid mentioned is this is a highly interactive coaching program, meaning we have monthly coaching webinars where you'll be able to actually submit your cases before the webinar, and Nahid will coach you through your questions about your case during the monthly coaching webinars. But before even that starts, we're having bi-weekly module webinars. We've already had 3. We have the next 3 starting on Monday with Module 4's webinar. And then 2 weeks later is Module 5's, and 2 weeks later is Module 6's. And those webinars will teach some of the module content, but also we'll look at members' cases during those webinars also. The other thing is under each video on the membership site, you can ask questions and Nihid will answer them. And in the Facebook group, you can post a case or ask questions and Nihid will answer them there too. So, this is a highly interactive coaching program. You're going to have the coaching webinars there to help you implement this curriculum. What we can do during the coaching webinars is you submit your digital files for your case, and you can be unmuted during the coaching webinar, and you and Nihid can talk about your case live online during the webinar. We do this with occlusion design, and it's been very popular. I've done this for years and years and years, and we just unmute the member. They can talk and ask questions about their case. We're talking real time, live, online about cases. So it's much easier than emailing back and forth, for example. So it's the ability to get real-time coaching on a monthly basis with your cases. So, basically right now you have 3 choices. You can, use this as entertainment and do nothing with it. You can learn all of this yourself, which some parts of this would be pretty easy to learn. The digital planning and digital design is not easy to learn. I think that Nahid's picked that up from multiple places and put it together into a system that works really precisely, and not many people are doing that for bone grafting yet. So he's kind of a pioneer for that. So, you could learn this yourself, but it would be pretty time consuming to do that. Or you can just join, you can choose to work with us and join GBR Online and have Nahid help you with learning and improving your surgical systems and your bone augmentation cases. And this is kind of like what I would call the easy button, really, because for a small investment, you can hit the easy button, become a member, and boom, you've got all this information about how to do this and monthly coaching for the next 12 months. It is a 12-month program. You do have the option of renewing your membership every year after that. It's been designed essentially the same as my occlusion design program. 12-month coaching program, core curriculum of training modules, monthly coaching webinars where in occlusion design's case, I show a case I'm working on, and then we look at members' cases. In GBR Online, Nahid will show cases he's working on, and then look at members' cases. Nahid is filming a lot of cases right now that we've returned to practice here in Ontario, and he'll have different clinical videos, live videos showing GBR bone grafting techniques each and every month. So what's the investment? The GBR Online program, we've envisioned this as a 1997 program, $1,997 USD program. We're having a webinar special right now, and you'll be able to save $900. Whoop, the fancy slide jumped away. So you can save $900, and there's our fancy slide. I think it looks pretty nice, actually. Hey, if you're going to save $900, you have to make a nice slide about it. So basically, you can pay one payment of $1,095 or 2 monthly payments of $590. If you were with us last month, you'll notice this is more a higher investment. The price has gone up since last month. We're going to do this on a regular basis. So this will be available now to the first, I guess we'll do 100 people again that join at this price, and then we're raising the price again. I'm not sure if we're going to raise it to 1,500 next time or 1,300 or who knows, right? We're not sure yet. But there's a 2-month payment plan, 30 days apart at $590. First payment $590, 30 days later. These are both in USD, US dollar. Pretty much everybody understands US dollar around the world. So that's what we use for the Felon Dental Seminars programs. And basically, GBR Online includes 6 awesome bonuses. Bonus number one, I've already spoken about, and that's the monthly surgical coaching webinars with Dr. Mohammed. So Nahid is actively starting to videotape a lot of different cases. Each month he's going to show a different surgical case with video and clinical photography and deconstruct that case and then look at your cases. So that's the beauty of these monthly coaching webinars. Bonus number two is a bonus package of videos that I put together. And it's essentially a series of different webinars that I've presented that show different grafting and guided implant surgery cases. So, and prosthetic parts of anterior aesthetic implant cases. So, one of the cases is this case. This is a screenshot from a video. It's not a photograph I took, where we extracted with the Benex extractor a central incisor that was hopeless. I did a socket graft that day. This webinar shows the whole procedure in detail, including the socket graft with a basically a Tarnow technique where we used a membrane and particulate. And then we look at, in the next webinar in this bonus package, the CT scan of this healed about 4 months later. And then the next webinar shows the guided surgery placement of the implant. So the second webinar shows the planning of the implant in the guided surgery software and creating the surgical guide. The third webinar shows the actual surgical video of placing the implant. And this is an anterior central incisor. So, you know, the big part about this is just deciding where we're going to place the platform, how deep to place the platform for an aesthetic case or an aesthetic outcome from a prosthetic perspective in the aesthetic zone. So this was an interesting series of webinars. We have a few others that are included in this that you'll get immediately when you join. The other thing that we've included is bonus number 3, which is a webinar that Nahid did for my occlusion design members called Minimally Invasive Soft Tissue Grafting Techniques for Teeth and Implants. It was a 4-hour webinar on soft tissue grafting. A lot of detail here. It's almost like a mini course about soft tissue grafting. This is going to be awesome for you that haven't seen it. We are planning to do a soft tissue grafting full course, full online course, sometime later in the year. But this will give you some basics and before we create that and put that together. Bonus number 4 is another webinar Nahid presented to my members last fall, Simplifying Bone Augmentation, a nice bone grafting webinar. You know, it's a nice little summary of techniques that are explained in significantly more detail in the GBR online modules. But if you run out of things to look at, which I don't think will be very easy because there's already a lot of content on the site, you can watch this webinar as well. Bonus number 5 is not released yet, but will be later this summer, and that's PRF applications in surgery. So Nahid has a master's degree in PRF, and he's going to show a whole detailed training about PRF applications in surgery. And then bonus number 6 is something that Nahid's going to videotape on a couple of cases over the next few months and probably release this one in September. And it's creating custom healing abutments for implants. He has a very nice system for doing this, and he'll videotape a few cases and share that with us. The other thing that we've talked about that we'd like to do is Nahid showed a lot of block grafting today. This is probably more particulate and membrane grafting, this course, but he'll do a webinar or maybe even just one of these bonus videos on block grafting. So those of you that want to understand the more detailed block grafting considerations and protocols and principles, he'll present a more detailed than today training about block grafting, because the digital block grafting techniques that he uses are quite amazing. So that is guided bone regeneration also. It's not really the vision of the course. The vision of the course is really for us, for Nahid to teach a lot of these particulate cases first and particulate grafting techniques, because it's so much easier for all of us to do that. The block grafting is much more difficult. However, he has a great system with digital technology to teach that, or to do that. So he's agreed to teach that in more detail in a little bit of time, probably in the fall. One of the members' webinars, I would guess. So once again, we have a GBR online Facebook group. This will be a a bonus for registering right now during the webinar. You can join the group, and as soon as we're finished here, Nahid's going to do a live demo of flap releasing and surgical suturing techniques. Now, if you have to leave, but you still want to join, you can go back and watch that video in the group afterwards. But I do believe there's some really cool uh, uh, applications to, or really just cool way to see it live and type in and ask your questions. You can't be unmuted on a Facebook Live. You have to type questions. It's just the way Facebook Live goes. But if you type your questions, Nahid will see them and he'll answer them as he's doing the demo, or take a break certain parts of the demo and answer all the questions. So it'll be really cool. I'm looking forward to it myself because, again, flap releasing is one of the most difficult, most important parts of GBR techniques, of GBR grafting. It's one of the most important things. Releasing is one of the biggest things. It's one of the hardest things too. As a general practitioner learning these techniques, I think flap release is one of the most difficult things to realize. And just this last module, module 3, took a lot of the mystery away from that and gave a lot of concrete technique plus flap design techniques, which will make your release easier. So what we can do now is just have a fancy slide and look at a few questions, and then I'll show you what some members say about the program. So if you're still here, Nahid, I'll just look at the questions.
Okay, just go ahead and ask.
Hello, I'm not a GBR member. Can I watch the Facebook Live right after this? Sorry, no, you have to join. You have to be a GBR member to join the Facebook group to then watch the Facebook Live. Again, it's not a very expensive program to join. It's $1,000. It's going to be more expensive later for sure as the months pass. So now is the best time to join, even if you take the payment plan. So, what will eventually happen to the tooth fragment on the facial of your PET case?
So the pet one, nothing is gonna happen usually. Most of the time, it just stays there. It's still getting its blood supply, and it just stays embedded like that. There's been some papers now published by I think Maurice Salam and
Uh-huh.
uh, their group, where they have I think now 10 years of data on these cases, and things still look good even after 10 years. I mean, mind you, they do have some complications. You do get, as a worst case, sometimes you'll get the root exfoliate or it gets exposed. If that's the case, you can just shave it down and add a connective tissue graft and hide it, or same thing, just pull it out later. But for the most part, if your shield is made at the right size and it's not putting any pressure on any of the prosthetic components, then usually it just stays embedded like the tooth was still there.
Perfect. Another question, I can answer this one. How long do you have access to GBR Online? And it's basically 1 year. So it's a 12-month program. You'd have access to June 20th, 2021, at which case you'll be offered the chance to renew. So if you enjoy the monthly coaching webinars, you would probably want to renew, because for $80 a month, you can attend a monthly coaching webinar, basically, which is new cases, new surgeries, and the opportunity to ask Nahid about your cases. So I think that is really cool. Another question here, how will the surgical skills like suturing and handling of the tissue be taught? It's hard to learn from just watching videos. Nahid, we talked about you're going to do some live demos during the webinars as we go forward as well. And I think you talked about maybe doing a suturing demo where people can get, what was it? There was a certain vegetable and then everybody can practice at the same time. What
Yeah,
was
we'll
zucchini?
make something available, that's easily accessible to everyone to get in practice. And, we go through literally whether you're in a classroom with me or on a screen, you're still looking at what I'm doing. I'm
Mhm,
not actually holding your hand. So you'll still be able to learn by watching. We'll break it down and do it step by step in certain times in live formats
mhm,
where you're following, and the more you do, you'll sort of be able to get a
mhm.
handle of it
I
you
think
know
suturing would be pretty easy for people to learn
it's not
how
Yeah,
to
it's not
do
too
as a
hard to learn.
live demo.
Yeah,
And you could also, like, we could plan this maybe for September, a suturing webinar
yeah,
where
and
you
we
could.
can have everything set up, tell you what to
Mhm,
get, and
mhm,
then we'll do it, we'll do it slowly, step by step, so it's
mhm,
very easy to just follow through on your own,
mhm.
and you'll be able to learn it.
I'd like
Trust
that
me.
too, because I haven't really practiced continuous sutures. It'd be good to practice. The other thing is, those models you used last month's Facebook Live, everybody could order one of those. They're not expensive, right?
Yeah, and they're just off of Amazon. Everyone can order it.
How much are
you know
those? Like $50,
There
$100?
depends on what it is. They can range from like 50, but depends. If it's a suturing model, you can get it for like 20 or $30.
Okay.
If it's a little bit more complex, then it's I think 100 or $150.
But all we need is that rubber suturing model for
Yeah, it's
everybody,
not
and they'd
it's not
need
a problem.
sutures plus the instruments, which they'd need
Yeah.
anyway. And then we
Hmm.
could do that. I think we should set that up for September or something. That would be fun. And
Yeah.
just with the document camera, go step by step, and everybody could follow along and do it on their own model. And I think that would be good times. Could be a lot to learn from that, I think.
Yeah. We
Hmm.
can preset like a suture clinic.
Yeah, suture clinic, online suture clinic. How cool would that be? And then what we
Yeah.
could do is we'll just send everybody the materials list of things they need.
Yeah.
Yeah, that would be awesome. How long of teaching is each module?
They alternate, but so far they've all been at least like around 3 hours or more. Some of them are
Mhm,
longer. The each module comes in with two things. There's the live webinar, and then there's the separate videos for each section of the module. So the content in the live webinar is also the same content that's in the actual separate videos, but the live webinar is a whole different. It's interactive. It's different. Some of the stuff may not be discussed in the live webinar that you'll see in the videos. The live webinars also have the section where people submit their cases and we discuss and go over cases and people are asking questions. So it's a whole different format, but so it's kind of different feel. So the
mhm,
live webinars so far have all been about 3 hours long themselves.
mhm.
And then the modules are about anywhere from like 3 to like 4 or 5 hours, depending on each one.
Yeah, so I can show right here. Here's module one. We and he did an intro video. Then he did the we had the live launch from May's video, and then we had the actual module one live webinar, intro to GBR and biomaterials. So he did this presentation, which was 3 hours and 36 minutes. And if you look here on the site, let me just turn the volume down on the webinar video because it gets a little too hard to watch. But what you can do is you press here to make your videos full screen. So just let's see. It's sometimes hard to make this work during, what have I done here? Sometimes harder to make it work during a live broadcast. Oh, there it is. Is that full? Yeah, it's made it full screen. So you can make each video full screen. Did that work? Oh yeah, it was full screen. It's weird because the
I
video
think it's
within the
video and video. It's
yeah,
jamming
it
up.
looks the same as the screen that I had up. It was confusing me. Yeah, so you can make your video full screen. You could forward and rewind, stop and pause. You can change the quality, although normally it's just basically 1080p. And each webinar has detailed training. Each webinar is detailed training of each topic. But then what Nahid's done is he has more details in the actual module videos. So each modules probably vary a little bit, but it's, maybe 6 hours long each module, I would guess, because of all the different videos in it. Maybe 4 hours, depending on the module. I haven't gone and counted up how long the modules are, but you look at module 2, it was the live video or live webinar. Then there was module 2, part 2, which was anatomy for GBR. Module 2, part 1 was anatomy. Part 2 was treatment planning and data collection. Part 3 was defect site analysis. Part 4 was creating a digital jaw model to 3D print the jaw model. And then part 5 was digitally creating a crown and implant placement for GBR planning. And then part 6 was how to create a digital bone graft. So this was very detailed training in module 2 about all the digital technologies. And then module 3 was a little more simplified because there were 3 things that Nahid wanted to teach. And there was the live webinar, but then there was part 1's instrumentation, so the instruments used. So that's about an hour and 20 minutes, that particular um, video. And then you go to part 2, which was incision and flap design. That was an hour and 25 minutes. And then you go to part 3, which is releasing methods, which was 36 minutes. So about 3 hours for the module videos, and then the actual module webinar was 3.5 hours. So between all of that, you've got another 6 hour module or 6.5 hour module. So this is probably about the average length of time for each module is in that range. So you look at the 6 modules, so that's a fair amount of content. And then you've got the bonus videos. So this program has a lot of content. By the time it's all finished, there will be a lot of detail and a lot of content there. Let's look at a few more of the questions. So Lucy says, I just signed up for the occlusion design program. Will I be able to sign up for GBR Online once I'm finished the occlusion design program? And yes, you can. We'll be relaunching this again by September at least. The only issue will be, Lucy, the price is going to go up. So if you wanted to join today, we sent the occlusion design members a specific email for them. You would have received it. You could join if you want, even with the payment plan, but put the actual membership on hold if you'd like for a few months. That way you can join up for the cheaper price and start your membership, the actual learning of the content, a few months down the road if you'd like, just so that you don't get overwhelmed with the 2 programs. Or you can just join later. It's just going to be a little bit more money. It's just because we're raising the price every time we launch it. It's just because we do envision this as a $2,000 program. You look at all the content already here. By the time Nahid's placed and taught even 5 or 6 of the monthly coaching webinars with all these case studies, there'll be so much material here. It's definitely worth $2,000. We're giving you a discount now, and we did last month because the course isn't finished yet. It's being built over the next few months. So you're getting a discount because you're buying while it's being built. So once it's finished, the price will ultimately go up to the $2,000. And I think it's well worth it. Just look at the suturing demo that we're going to do, kind of workshop, online workshop. That's worth maybe not $2,000, but it's worth a significant amount of money right there. We could probably sell a whole bunch of tickets to that, and that would be very popular. But it's included with your GBR Online membership. So, let me see. I just signed up, but I would prefer to start learning in the fall. Just email Amanda and we can reset your start date if you'd like. But you wouldn't attend the next, 2 months of webinars. If you start later, you can take advantage of the discount and just start attending in whenever it is you want to start. So that would be fine if you'd like to, but you can still attend today's Facebook Live, obviously, and be access or have access to the Facebook group. That would be cool too. Um, do I get certificates after learning from the webinars? So each of the webinars in the GBR online program, if you attend the actual live webinar, you will get CE points. We do offer CE points for the entire program. Let's see. Let's look for some of the questions for Nahid as well. Here's another course question. Do we have to commit certain time to attend the teaching, or will it be available for members to watch them at a different time? So each member webinar is posted to the site, so you don't have to attend live. You can basically just post or just watch it on the site afterwards if you can't attend live. That's the beauty of an online program. Let me look for a few other questions for Nahid on the clinical end. What does STL stand for?
Oh, STL is a stereolithograph, but it's basically a 3D model, like a digital 3D model file.
Yeah. How much is it to use a company service to make the STL file from segmentation, and which company do you use?
It depends on how much you want to segment, and it also depends on who's doing it. It can range from anywhere from $50 to $150, depending on how much they're segmenting and all the details. I use a 3D image conversion. It's an online company, but I think they're based out of India, but they have a good price and they have a good return where, once you upload your data within usually 2 days, you have the results back. So they've been pretty good and the price has been good.
Yeah, that's a good deal, really.
Yeah, and if you join the course, I explain how you can do this and work with them in one of the modules. So
Mm-hmm. In module 2, basically, right?
in module, yes, all the information will be there.
Mm-hmm. Is the merging of the JPEG and STL file also done on Blue Sky?
You can import a photograph and merge it on Blue Sky.
Hmm. And what software do you use to merge the databases together?
You can use multiple softwares, but this one is Blue Sky Plan is what we use in this one.
Okay.
I use Blue Sky Plan most of the time for this course because it's free.
Yeah.
So because we have members from all over the world, anyone can just download as long as you have the internet, and you can use it for free. So it just makes it more accessible and easier for everyone to work with the same software.
Yeah. In an altered vertical dimension case, how do you determine the occlusal portion in STL?
Well, an STL really, if you're looking at teeth, it's just an impression. It's just a digital version of a cast.
Mm-hmm.
So if you
It's
were going to
not
do
articulated.
everything digitally, you'd have to have a digital articulator and you'd have to have it done properly with a proper lab. But there are softwares and programs that do it. I'm not the best at a restorative question like this, but
Mm-hmm.
Stephen, do you know any of like any software that does digital articulation?
Well, I believe 3Shape's new planning software
I
has
think so, yeah,
that.
3Shape does it, Zircozan does it
I think
too.
most of them do now.
Yeah,
Probably ExoCAD would too, for sure.
yeah, a lot of them all do. They all have digital articulators, so you're basically just doing the same thing. It's just on the computer instead of on a real articulator with
Yeah.
casts.
Yeah. Depends on what you like too. Um, okay. Are you using BSB for socket shield planning also? I guess Blue Sky
Okay.
Bio.
You can, yeah, you can do it. I can do it. Depends. It depends on. I have Co-Diagnostics and Blue Sky Bio, so you can do it on Blue Sky Bio as well.
Mm-hmm. Okay.
I think the case that I showed, I can't remember if I used Blue Sky Bio or not, but you
Uh-huh.
can definitely do it though.
Nice. Um, I don't understand the purpose of leaving a small layer of buccal root because we will not see the root visually compared to the crown.
So the purpose of leaving the root is not, it's not for the root itself. The purpose is to preserve the bone.
Yeah.
Buccal bone is very thin. So part of buccal bone is what we call bundle bone. Now, bundle bone itself is usually almost 50% of the buccal bone on average. So that bone receives its blood supply from the PDL. So when you remove the tooth, the PDL is removed as well. So the blood supply is disrupted, and that's what causes most of the buccal bone loss and buccal remodeling that we see after extraction. So by leaving this root in place, you're leaving the PDL on the facial part and thus giving or maintaining that blood supply to the bone so that you don't get that bone loss or bone remodeling. And so the purpose is really to keep the contours of the bone so that you have a more aesthetic final result.
Mm-hmm. And what will happen to that remaining root fragment?
It nothing, it just stays there just like it's embedded in there.
Mm-hmm. Were Herzler and Zur the people that did, kind of
Yeah,
invented
they're
this?
the guys that first documented and reported
Mm-hmm.
this technique in this case.
I remember seeing Otto Zur at IDEA, and it might have
Yeah.
been early 2010 or 11, and he showed that. And it was, I think, the first time I'd seen it, maybe 10. It was a while ago. For socket shield case, did you use guided surgical guide to place the implant?
I did for just for the pilot osteotomy.
Okay. And did the
But yeah,
guide
you can
help
do it. You can do
you?
it all guided. It
Mhm.
doesn't.
Did the guide help you section the root properly?
No, the sectioning I did freehand just based on my digital planning.
Hmm.
But there are guides now that are starting to help with that. But no, it's nothing is so far as accurate. It's easier to just do it freehand. You have more control and
Hmm.
it's easier to see. But technically, you could make a guide with the right angle to be able to allow you to do this. You'd have to be a little bit creative, but it's not impossible.
Hmm. Assume the uh, periapical pathology of the root would be a contraindication for socket shield. Obviously, yeah.
Yes,
Um,
it is, but we also, the apical portion of the root is always removed. So the
yeah.
buccal portion of that shield is usually more of the coronal two-thirds of the root, not the
Okay.
apical.
So it's kind of a shell of the outside.
Yeah, it's basically a shell. That's why they call it a root shield, because it's like a little shell.
Yeah.
More,
So it's not a
you know,
ton.
basically, yeah, it doesn't go all the way to the apex of the root.
Yeah,
It's
that
just
makes
because most of the
sense.
contour is on the coronal portion, not at the apical end.
Yeah, that makes sense. Okay, let me just see. What software do you use to do all the segmentation? I think you talked about that.
Yeah, boot sky plan.
And what about Mesh Mixer?
Yeah, we use a mesh mixer too as well to do some of the manipulation to the digital files.
Hmm. I remember you showed that
Yeah.
in the module. Do you
Yeah,
release
like
the
the digital
peri?
bone graft in mesh mixer.
Yeah. Do you release the periosteum prior to your sutures or after?
Well, well,
I
you
think
can't
maybe
release the
that's for the
periosteum.
sutured membrane.
Yeah. So I always release my periosteum right after I reflect the flap,
Mhm.
because the reason being is when you reflect the flap, you have time before you close it. So if there's any bleeding or it's all clotted and under control before you close up the flap. Because if you close up the flap, a lot of times people will do it right before they suture, so they'll score it, close it up, stretch it, and then start stitching instantly. But what happens is it starts to bleed underneath the flap. So when you have a lot of blood underneath the flap, you have a couple of things. One, more bruising, more swelling, number two, and more pain. So by
Mm,
doing it ahead of time, you've clotted and controlled it. It reduces the amount of swelling and bruising and discomfort, and patients are happier. And it's
nice.
one less thing you have to do, especially once you have your bone and everything in place. You don't have to sit there trying to fiddle and score the periosteum around your membrane and bone graft.
Yeah. And the membrane suturing you made look easy is the comment. You'll show how to do that in that module.
So module 4 is actually going to cover that. Yeah. So actually Monday's module, you're going to see it. And then I think I'm going to do a live demonstration as well
Nice.
of doing the membrane suturing just on a model, just so that you guys can see it step by step. But there'll be a video showing that as well
Mm,
as part of the module.
that's a good idea. What type and size of suture is used to hold the membrane internally like that? I guess that's
Um,
Monday.
but technically you can use any size. I personally just use either 5 or 6
Hmm.
sutures. But that's just because I use majority of those sizes. But you can use a 4 as well.
Hmm. Is there a particulate size that works best?
Depends on what you need. The only time I use a large size particulate is in the sinus, but in ridges, I use usually between like 250 and 400 microns.
Hmm.
It remodels faster because I don't want to go in and find chunks of unremodeled particulate. So you want to have a smaller one so that it remodels fast, but you also don't want it to be too small that it doesn't sustain and hold the space long enough. So usually
That
between
makes
2 and
sense.
400. I think in module 1, when we discuss bone, there's a slide that discusses what the ideal size
Yes,
of particulate is.
you did that. You broke that all down
Yeah.
in the biomaterials section. Mixed plasma, how does that help, please?
Take the course, I'll show you. It's so basically the the point of using, I'm assuming platelet-rich plasma and all of these factors is you have natural growth factors in your blood that are released by your platelets. So by using these, you're adding these growth factors to your surgical site. Now, research has shown it doesn't help too much with bone, but where it does help is create that stickiness to your bone graft material. So it helps with bone graft stability and space maintenance.
Hmm,
And, it helps remodel faster, but it's also good for thickening and keeping the soft tissue healthy.
cool. What 3D printer do you use to do the multicolored 3D printing models?
That is done by my radiologist. It's a Stratasys 3D printer. These are very expensive. They're like over $100,000. I think the one he has is either 150 or $250,000. So normally it's not cost effective for you to have it. These are people who manufacture or do a lot of 3D printing to have them.
Hmm.
So, but that's why when I do it, I use his.
Yeah, no kidding.
And they're big. Things are like huge. They look like tape. They're the size of like a big table. They're not small.
Wow. Okay. You know what I'm going to do is I'm going to show a couple of the members' testimonials, then we'll do some more questions. So, what members are saying. So, this is Lawrence had said, congratulations to Nahid Mohammed in providing such an excellent GBR online course. The program is systematically well organized, up to date, detailed information. His teaching is well presented and precise in explanations. All are of clinical relevance to our daily practice. And then he said, this is one of the best GBR courses which I've ever attended. So that's very nice. And then Thomas said, Dear Nahid and Stephen, just wanted to write to tell you how happy I am with the GBR online program. It's full of valuable information that is practical to my practice. And the amazing bone grafting results that you show are truly inspirational. I now look at what used to be a hopeless situation and realize that with good techniques, almost anything can be done. Thanks for having this program. So that's cool. Um, Monica, the course materials and style delivery exhibited by the various teachers are very awesome. I look forward to each lecture always. And then Dr. Parth is in academia. So he said, being a full time academic, in the Department of General Practice, I wanted to improve my understanding of the science and clinical practice of implant dentistry, especially site preparation and treatment planning. Dr. Nahid Mohammed is easily one of the best instructors in the field. His presentations are comprehensive yet not cumbersome. So it's, detailed training, but not to the point of being hard to follow. His language is simple to follow, and he spends a tremendous amount of time to prepare his slides. He strips all the peripheral issues surrounding the topic and identifies key areas that general dentists need to focus on to achieve optimal results. His hands on approach to teaching, as well as clinically relevant tips, are immensely helpful. Kudos to the whole team of Phelan Dental Seminars for organizing the lectures and making them available online immediately for those who could not be present for the live lectures, meaning the module videos. The module webinars, the replay videos are usually posted the next day. Discussion of the member cases adds to problem solving as it happens in our clinics. And I think that the member cases add a lot to the live module webinars. Joining GBR Online was an easy decision for me, and Dr. Nahid is exceptional. If you are interested in learning from one of the top clinician educators in the field of bone regeneration, jump in, you will not regret it. So there you go. Few people. We did add, we sent everybody an email a few minutes ago, and it showed even more testimonials than this. I didn't have time to put any more than this in. Just ran out of time putting it together. There were so many of them. It was, we've got more of them in the email. And then as the course builds and we finish the content, there'll be even more members telling us what they think. So again, in a few minutes, we're going to leave after I ask Nahid more of the questions, and we'll have this demo of flap releasing and suturing techniques live in the Facebook group. So you'll want to get joined so that you can join the Facebook group and get in there today, because this is going to be really cool. How do you plan to elevate the flap and remove the tori? What kind of burrs do you use to cut the tori? It's a good question.
Well, usually, I mean, elevating the flap is just like how you would elevate any other flap. You make your incision and you just reflect with the periosteal elevator. Usually, as you work around it, the mucosa can stretch and you can kind of get around and lift it. And then I usually cut tori with either it depends what I'm doing. If I want to preserve as much of the bone, then I'll use a piezo saw to cut it. If I'm not and I just want to just get it out of there quickly, I just use like a 702 or 703 surgical burr on a surgical handpiece. I score down through like as deep as I can, almost all the way through, and then I just use a chisel and a mallet and I just tap and it just pops off. And then I usually take a round diamond burr and smoothen out any rough edges to just smoothen out the contour.
Makes sense. Okay. How do you segment the bone grafts? I guess we just
I
said
get someone to do it for me.
in the digital planning, yeah.
Yeah, you can do it yourself. You just basically have to go like each millimeter slice and trace out the bone. Like there's a segmentation tool in the software. They'll ask you and you pick what you want to segment, and then you literally go slice by slice tracing it. But it takes like sometimes an hour or so to do.
Yeah,
And it's just very time consuming and boring. So for me, my time is worth more than spending it doing that. So I just outsource it to a company and they do it for me.
makes sense. Makes sense.
Yeah.
In the tori case, why don't you place the implant, mix the tori bone with a low resorption rate xenograft and a membrane?
Why don't I?
But yeah.
So you could do that, but why would I use xenograft bone when I have our own bone?
Yeah.
There's enough tori there. Tori is thick cortical bone. It doesn't need any xenograft in there. There's no reason to add the xenograft, so you're just wasting your money on materials. I mean, there's enough cortical bone there in tori. So, I mean, to me, it's easier. And also, if I use all only autogenous bone, I could have placed the implant at the same time if I wanted to, but sometimes it's, one miracle at a time. I just didn't want to risk it because cortical tori bone is very dense. It's not as vascular, so I preferred to stage it. But yes, I wouldn't have added xenograft, but I could have placed the implant at the same time.
Cool. Um, let's see. Amazing. I've used the tori as a bone source before and it worked well. I've reached out to a couple of periodontists and they told me that the tori is no good because of the cells from a regeneration point of view.
So what they mean basically is tori itself as a large block is very dense cortical bone. So that means that there's not much vascularity in it. So if you were to take a whole chunk and just screw it in, a lot of it doesn't remodel properly, or you get a lot of dead bone sometimes. So in my case that I showed, we cut it into slices and we're using the bone plates as sort of like almost like bone membranes per se, but then underneath is a particulate. So it works a lot better like that. But again, a tori, technically, I've used it as a full block and it's worked. So it's not the best bone for just doing it as a large block, but they do work.
Okay.
And I mean,
Why?
you saw the case. You can't
Yeah.
argue with the result.
Yep, yep, for sure. Why are you adding particulate bone over a block?
It's more for padding because I just usually it doesn't stay, it remodels, but the blocks are usually square. So when I add particular bone around it, it just smoothens the contour so that when the flap goes over, it's nice and smooth and there's no sharp ledges or edges. So that's why I do it.
Mhm. What camera are you using for photography?
I use a Canon 70D.
Hmm, okay. Well, we have to get you onto Nikon there, Need. Okay. How do you determine the thickness of the block graft?
Well, it depends what I'm using it for. If I'm using it to act like a space maintainer or a membrane, then it can be usually about, I like them about 1.5 millimeters thick. Usually when they're thinner, like about 1 millimeter, you could use them, but I find it gets some resorption.
Hmm.
So I like them to have a little bit more strength to them. But technically, I mean, bigger blocks can be about 2, almost 3 millimeters if you're using them like a block itself. But it all depends on the actual defect side itself.
Hmm. How long do you wait after grafting to place an implant?
Depends on the bone material that you use.
Okay.
If you're using xenograft, you have to wait really long, at minimum at least 6 to 9 months. If you're using allograft, usually between probably 5, 6 months, you should be okay. If you're using autogenous bone, 4 to 5 months.
Okay. What's the percentage of mixture do you prefer grafting autogenous with allo or xeno?
It's usually close to like a probably 40-60, 40% autogenous.
Mm-hmm. Serena's asking, Dr. Fallon, is the charter membership for GBR still available? This is amazing. Thank you for putting this together. Basically, no, the charter membership was a little bit less price. We've raised the price. I did say when we launched the charter membership a month and a half ago, that was the only time it would be that price, and we've raised it. So I was telling the truth. And I'll tell you now is the only time it'll be this price. It will raise again. So, yeah, it's basically good time to join if you want the best price. What's the name of the block approach? Corey.
Yeah, Curie technique.
Yeah, that's from, what's his first name?
Fuad. Fuad
Fuad
Khoury, Professor.
Corey, yeah.
Yeah.
He has a good book in Quintessence, and he has a course at Idea. That's. Did you
He's
go to the
actually,
Idea course?
yeah, I went to the idea course. So he's actually making a new book.
Oh, okay.
Like his book that he has is older, but I think in this fall or this upcoming year, he's
Hmm.
gonna release the new version.
Hmm. What screw system are you using for block graphs?
Depends on the size of the block, but I have Stoma and Salvin screws.
Ah, good. Uh, the air stuff is very interesting. How far do you feel we are from this becoming more user friendly?
Uh, I mean, I think it can be used now. Like the technology is there. It's just no one really has thought of it in the dental field.
Hmm.
But they're already doing it in the medical field. A lot of this stuff. It's just it's expensive and the equipment and stuff is expensive to have that headset, and you have to have it where it's not interfering with your own vision to do the procedure. So
Hmm.
we're getting there, but right now there is no actual software to do it. So when we did it, we were really hacking other softwares and playing around with it. So it was really tough to do.
Mm.
But definitely now the technology is there. If just someone were to invest the money into making it into a dental application, it could be done.
Yeah. Is it possible to see how you created the customized healing abutment? I would say that will be a sixth bonus video in GBR Online, right, Nahid?
Yeah.
That's
Yes, that'll
something
be one
you're
of the
putting
bonus
together.
videos.
Hmm. Do you have any complications, especially when you make a chin or ramus graft?
There are risks of complications. I haven't had any uh, because I guess you have strict rules that you got to follow. There's
Hmm.
muscles there, there's nerves there. You have to understand your anatomy, and if you follow the rules and you do everything right, you won't have any of the complications. Some of the ones that they say is like they call drooping of the chin and sometimes nerve disturbances and things like that. And that's only because they've either reflected too much and they haven't put the muscle insertions back into place. So it's also if you don't care for the muscles while you're in that area,
Hmm.
then you can have complications. But they are rare, to be honest. And it's if anyone who's learning to do these are taught how to do it right. So as long as you follow the rules, you should be okay.
Okay, perfect. What is the name of the facial scan app?
The one that's on the cell phones now is called the Bellus 3D Face app. Bellus.
Yeah. Can you talk about recommendations for post-op medication?
That's in module 5, I think. Yeah. So yeah, we go over like talking about. So usually with post-op, just as a brief summary, most of the time there's analgesics, so pain medications, and antibiotics. Okay, so antibiotics, depending on whether they have any allergies, it's usually a 7 or 10 day course. Analgesics, again, it ranges from things like ibuprofen to like Tylenol 3s, Toradol, and sometimes something even stronger if needed. But that's
Mm-hmm.
pretty much it. And then I don't usually use chlorhexidine anymore unless I really feel I need it, but I just have them rinse with warm salt water post-operatively.
Mm-hmm. Sam says, I just sign up. Do I get an in Facebook invitation to join GBR seminar group? On the page after you signed up, Sam, it had a link to the Facebook GBR group, and then you just request that you join. If you're not sure, maybe Amanda can send you an email with the link to join the Facebook group, but you have to request to join. I forgot to mention that to everybody, but when you join a Facebook group, if it's a closed group like this one, you have to request to join, and then we approve you. So everybody who's joined the program gets approved. We just have to manually do it, so it takes a couple minutes. So yeah, you will be able to do that, Sam. That's no problem. Oh, Jennifer's just texting me. Let me see. It's in the welcome email too. Okay, so Jennifer just let me know in the welcome email you receive about congratulations, you've joined. There's a link to click that you'll be able to get into the Facebook group and ask for access. So you just request to join, I believe. Do you demonstrate sinus augmentation? That's funny, Nahid, because you just showed me that whole huge sinus graft you just videotaped this week, right?
Yeah, so this past week we did a sinus graft surgery that we filmed, so that will be probably coming up in one of the upcoming monthly webinars.
Yeah, so you'll show that, and that'll be a cool
Yeah,
case to see.
yeah, that patient actually has his other side, the other sinus that's going to be filmed as well in the next few weeks. So
Yep.
when I show that case, we'll show the whole bilateral case and we'll go over the planning and stuff. His case is interesting because he also has an artery that runs in the bony wall. So we'll show how we segment it and find it digitally and how to avoid it.
And the case you and I spoke about yesterday, where
Yeah,
you're bone grafting the sinus and doing a GBR procedure on the lower, you're going
yeah,
to videotape that whole case, and then I'm doing the pros. So that'll be one of those cases where we kind of collaborate on the presentation, which will be pretty cool. But it'll probably take a year and a half before we finish the case the way it looks.
yeah.
I'm starting it this week. You're doing work on it in next month, but it's going to take a while. It's a bit of a difficult, messy case. Greetings from Somalia. It was my pleasure to attend this well organized webinar. Thank you very much. Oh, well, you're very welcome. Isn't that cool, Nahid? Somalia.
Yeah. Oh
People
yeah.
from all over the world. Very cool. Is PRF equivalent to PRP? Too many PRs.
Yeah, there's kind of the same thing, but they're not. We do have a bonus module on PRF and PRP and all of them, which I'll sort of be discussing the difference.
Hmm.
The main thing really, they're both made from blood concentrates. The growth factors come from the platelets. The difference is PRP is like a double spin protocol, so it's more concentrated, and PRF itself is the fibrin, whereas PRP is just the liquid of the growth factor. So they're slightly different, but the source is the same.
Hmm. Cool. Um, as a tech, Zirconzan
Hmm.
is the best software. This Leah's mentioning. Haven't heard of it. How do I get a membership?
The link.
The link. There's a
The
link.
link on.
It's right here on the page. phalendentalseminars.com/GBR online digital. We did send an email to everybody. And yeah, good time to join, as we said, because the price will go up after this. Oh, greetings from Nicaragua. Wow, we've had people from all over the world again. That's always really cool. How do you spell Corey again?
Khoury.
I'm glad you know how, because I don't. I'm terrible at spelling, um, admittedly. So let's see if we have any other questions. I know I may have missed them. I'm sorry. But if we have any other questions, you can ask them now. Otherwise, it's kind of last call to join GBR Online and attend our Facebook Live in a few minutes. Um, just, go to the link here. We've got a link in the chat too. Where is the chat? I've lost the chat. Oh, I had closed it. So if you open on the GoToWebinar control panel, go down to where it says chat and make the triangle go downwards as opposed to sideways. It'll open a box and it has the link to GBR Online registration right there. You just click on that and it'll pop you over to the page that you need to go to. Actually, I can show the page, Nahid. Let me show it
Sure.
quickly. Where is the... Oh, did I close that? No. Here we go. Oh, that's the website. Here it is. Okay, so this is again, it's, whoops, I got rid of the URL. So yeah, the URL's down below. There's the website. So we're offering a webinar membership offer of saving $900. Again, this will go up after this and it'll be more expensive next time we release it. Last month we released it at $995. This month it's $1,095. Might go up to $1,500 next time we do this. I'm not sure. But this page shows you everything you need to know. You can click here to actually join. This gives you the single payment option or the two payment options. Very simple, just to enter your info here. As soon as you enter everything, you go to the next page, which will give you your link to join the Facebook group. And then the other thing that that will give you is, yeah, is the link to join the Facebook group. You'll be emailed your access to the site. So this is the site here, a picture of the site. Module 1 is Introduction to GBR and Biomaterials, very detailed training. Module 2 is Anatomy for GBR, Site Analysis and Treatment Planning, already done, and very good detailed training. Module 3 is Instrumentation, Incision Design, and Flap Management and Releasing Techniques. And this is already done and detailed training again. This Monday, Module 4 starts with the live webinar, Preparation and Placement of Biomaterials, including all the PR stuff. PR, whatever, sticky bone stuff. And the big thing in this one is membrane management of the biomaterials. So the tacking of the membrane or the suturing of the membrane. That's between the releasing of the flaps and the flap design and the stability or stabilization of the membrane. As a clinician doing this kind of work and being, I'd say, a fairly big, pretty much a novice, but good clinician. This is just my own experience. I'll tell you that I think that these are the two most maybe challenging areas that Nihid is breaking down into detailed step-by-step training. So managing the membrane and tacking it or suturing it is very important and something that's not very taught very well. And then the releasing and design of the flap is not, I don't think, taught well either. I've taken a ton of training on a lot of different places and can't say that I've learned it as well as maybe I've learned just from Module 3 and what I look forward to learn from Module 4. So I think that this is really, really good deconstructing the whole process. And particulate GBR procedures are something as general practitioners. I know there's some specialists here, but as general practitioners, we should all be able to do, but we need the training to do it. And then suturing, postoperative care, and complications. You know, suturing again is something that we could practice. We're going to do a suture clinic online and we'll be able to practice and learn how to do this pretty easily. And then simultaneous GBR and implant placement, that is so critical. There's so many implants that you would place that could use some simultaneous GBR. And again, I've taken the courses. But I can't say that I've taken courses that go into detail like this will about flap design and release and then membrane stabilization. To me, those are the two big appealing parts of this program that will help me personally in my practice. So again, you've got some testimonials here. We've got our member bonus package. It's all laid out and given to you in detail on this page, the phelandentalseminars.com/GBR -online -digital. Again, he's going to do a PRF bonus package or bonus video. He's going to do a custom healing abutment for dental implants, creating that video. And then we've got the Facebook group. We've got CE points included with all of this. You know, this is a big package for $1,095. As I said, this is going to be $1,995, but for now, because it's still being built, you're getting the best deal you'll ever get, and you're able to join for $1,095. It's like really good deal for this comprehensive level of training. This much detail is really outstanding for that kind of small investment. Really, it's way less than the cost of one case. You actually do one case because of this program, and you've well multiplied the ROI of the program, like completely. This is potential to have a massive ROI in your clinical practice for the rest of your career if you think about it that way. Huge ROI, really. And the ability to do more implants in your practice increases the ROI exponentially as well. So I hope all of you can, or a lot of you can join, because I think this will be really good. Let's see, there might be a couple more questions, and then we'll be done. What does harvesting mean exactly?
Harvesting just means to take the tissue out of the donor site. So if when we talk about harvesting bone, meaning I'm taking bone away from like taking bone out of the site to use for
Yeah.
the surgery.
Hmm.
Like for example, a chin bone block. I'm harvesting the bone block, meaning I'm cutting out and removing the bone block so that I can use it for the bone augmentation.
Makes sense. Okay, so we'll see. Anybody have any more last minute questions? Sorry, I've scrolled down. There were so many. I might have missed a couple. If you do, let me know. Otherwise, I think we're about to end and start the live demo in about 15 minutes. Nihid has to kind of get himself set up. It's mostly set up, but the pig jaw's in the fridge, so he doesn't have to smell it all this time. I assume it's still in the fridge, huh, Nahid?
Hope so. Hopefully nobody ate it.
Can you
No, it's in the
imagine?
fridge.
Somebody barbecued it up. What about yeah, that's funny. It's not in the fridge that you put your lunch in, is it?
No, no, we have a different fridge for materials and stuff, but it's sealed in a bag and everything.
It's in a
It's
bag,
not
yeah, so it's good.
wrapped up nicely.
Good stuff. Let me see if there's a couple more that I might have missed. Pig heads are available from your butcher. Yes, that's where Nahid got
Yeah.
his, right, Nahid?
Yeah, we get it from a wholesaler
And how much
supplier
did it
that's
cost?
this one they charge $25 an arch.
Oh,
So
so
just for the mandibles, $25.
that's not a big deal. So
No,
instead of the models, people could even get a pig's head if they wanted to.
yeah, just go ask your butcher and they'll like I get it from a wholesaler, so usually when I order one, the pig is either sacrificed the night before the day, so it's a fresh pig. So the tissues and everything are still soft and there's still blood in there. It's not like a frozen thing.
Nice, nice. So that makes it easier for
Yeah,
practicing
it's
on, I
easier
would
to
assume.
manage. The tissues and everything are more like natural.
Hmm. Hmm. That's really good. Really cool. How long are the monthly webinars? Well, I think we talked about that. They've been averaging 3.5 hours, right?
Yeah. They-
You
They're
sound
just long.
tired just saying that.
Well, because after a full day of work, I literally come home and it's like the webinar, and by the time it's done, it's like almost midnight, and I'm done.
So
Like I told you
I
the last
told you
time.
this when we started. I
Yeah,
learned the hard way that a full day of practice and then a webinar is not usually the best recipe.
yeah.
It's
Now
tough.
once we do the other webinars, I can leave work a little bit early on those days.
Hmm. Hmm. Like for the most part, I try to block the day off if I'm doing a member webinar in occlusion design. Although in the summer, typically I do them on Wednesdays and I do work Wednesdays before, but I try to finish early and have it a lighter day because it's
Yeah,
tough. You know, you do a full day, like a hard day, and then you have a 3.5 to 4 hour webinar that night. You're going to sleep hard that night after that, you know?
yeah,
Yeah. And the next day, yeah, it's good if you don't have a huge day the next day too, if possible. But
yeah.
it's yeah, it's a grind now that we're back at work, especially. Hmm. But that's all good. It's all good. Let's see. I exited from the sign up page and cannot follow how to sign up for Facebook. Can you email me or right here how to join the Facebook group? So if you went into Facebook, Sam, and just did a search for GBR Online, the group will come up and just request to join. I believe that's something you could do if you did a search. Let me see if I can get the group up. GBR Online. So I don't really, to be honest, I don't go on Facebook personally. I go into my member group occasionally, but I typically don't otherwise go on Facebook. So that I'm not that much of a Facebook guru, so to speak. Okay, so here's the group, I think. Oh, that's the occlusion design group. Sorry, let me just find the other group. Oh, here it is, GBR Online. Okay, so here is the GBR Online Facebook group. And we're going to have a watch party soon. Oh, they started the watch party with our test. So we did a test, everybody, about 3 hours ago to make sure all the technology was working. And somebody started a watch party, but that's cool. We deleted the video though because it was only a test. So we're about to start the real video. So yeah, if you just search in the Facebook, here it is, the search thing in Facebook, just do capital GBR and then capital O and then lowercase online. The group should show up, and then you'll have to request to join the group. Now, if you request to join the group and you haven't joined the GBR online program, you're not going to be approved. Okay. um, it won't happen. There's no online GBR online group found in Facebook. Well, Sam, there is. Amanda or Jennifer, can you guys email Sam, SADATI, the link to the group? We'll email you the link again, Sam. But if you go into the email you received from Phelan Dental Seminars after you joined, I think it says congratulations. It will show you the group. Like it'll give you the link to join the group. So like lots of people are requesting to join, so they're obviously finding it. But yeah, I don't know. I'm not really much on Face. I'm not really super organized about knowing using Facebook, so to speak, if that makes sense. I don't use Facebook, so I'm not sure. But I'm sure, like I was pretty sure if you typed in GBR Online, you'd find the group. So
Yeah, I think there's a place you can. I don't really use Facebook that much. I just use it for this GBR
for this,
online
yeah.
stuff. I'm still learning, but there's a search for searching groups and then you can just type it in and it comes up.
Yeah, but a lot of people are joining right now and asking to join the group. So
Yeah.
obviously it's working. It's just it is you're not having an easy time. Oh, you found it. There you go. It won't let you join. All you have to do is, well, you have to request to join, Sam. I don't know what it is. I think you just ask to join.
Yeah, I think you just request and then you'll get access once the administrator just
Yeah,
approves the request.
they're in there right now approving people, so you'll get approved right away. Um, as soon as you ask, like within a few minutes, you'll get approved. And you can see if we scroll through the group, Amanda's administering this course and she posts every time something new is in the group. And then different members can post things. People can post cases. Here I posted wearing all this crap when I went in for an emergency in May, and it wasn't pleasant wearing the N95 and all that stuff. Here is the actual live stream from last month, and that Nahid was showing some suturing techniques. This is like the suture model we're talking about that everybody could get if they don't want to smell a pig's jaw. in their room when they're practicing on our suturing workshop. And you can see it here. If I can, yeah, I can forward it so you can see the what do you call it? The DocuCam video camera is really good for demoing procedures. Hold the flap in place. Then the next step would be to go in and do my sometimes. So you can see he's doing some mattress sutures, and then did continuous suture, and then he showed a socket grafting, really cool X suture for the socket grafting. Yeah, so it was pretty cool. This was a good little Facebook Live, and then today's will be different, but we're using, instead of the model, we're using a what do you call it? A pig's jaw.
Good job.
Yeah, and then this will be here afterwards. If you want to watch it, you can watch last month's live stream too. It was, it was an hour. Yeah, it was over an hour of training. And even one of my associates watched it, and he really liked this technique, Nahid, with the socket grafting. That was really cool. So, and then, oh geez, look at that. Your videos covered. So here's another video that Nahid released. And you were going to actually show a little clip from the sinus graft as well, you said.
Nice.
Yeah, so he's going to show that little clip in the Facebook group maybe in the next couple days. So it's kind of cool. Here's another little clip that he placed in the Facebook group. This is from a pig's jaw too. But the quality of the videos is quite nice. Look at this. Really good. Really good. Okay, so I'm assuming, Sam, that you're in now, I hope, to the Facebook group. We'll make sure we get you in. It shouldn't be a problem. Let me see if there's any last minute questions. Then we're going to go, because our target was to get into the Facebook group at 3. I think we're good. So everybody, if you would like to join, this is our last call. We'll be starting at 3 p.m. for the live stream. Amanda, you can send the email now saying we're starting in 15 minutes to all the members, new members plus old members. And yeah, that'll be about it. Anything else, Nahid, you can think of?
No, we're good. I think I'm just gonna go set up then.
Yeah, Sam says he's not in yet. I don't know what the problem is. Oh, there's one more comment I'll just ask you about. Sorry, as a full arch implant restorative digital designer, I find that the Zircon Sans design module is the best for setting the occlusion for those types of restorations. Ah, okay. It's important for me to keep up. Okay, so Leah was, I think Leah's a technician from the gist of this. So that's kind of, I wonder if that's what Picos is using. We were talking about that earlier, Heed, for his full arch.
No, he uses ND sequence.
ND sequence, yeah.
Yeah, yeah.
See, personally, for me, I'm not interested in any of that because that's just not my thing. And I just don't get those patients here in Oakville. Do you get many of those in Oakville? I don't seem to get any in my.
Not as many. I mean, everyone here has good teeth, but
Yeah,
we get a few,
it's a
like,
different demographic, isn't it?
yeah. Like I don't get as many as I would like, just because
Yeah,
they're more fun to do. But I get maybe just a few a year.
yeah. I don't get them here in Oakville.
Like I work with, like my name has become known around the city, so I get referrals like from other areas.
Hmm.
So I work with a lot of prosthodontists, so they'll send people from like Toronto out to see me here for the surgery, and then we'll like book the immediate loading on the same day where he'll come to the office and do it. So
Yeah, I guess.
yeah, like most of my full arch cases come from the prosto guys.
Yeah, yeah. I do a lot of full mouth rehabilitation, but they're all on people that have most of their
Yeah,
teeth. We do maybe
yeah,
a
but we
few
don't.
implants as part of it, but most of the people have most of their teeth. It's just the demographic, I think, in this area.
Mhm.
Oh, Amanda sent out the invitation. Okay, and Amanda, in the Facebook group, can you make a post right now saying it's starting at 3 p.m.? We'll plan to start at 3 p.m., Nahid.
Okay.
Yeah, that gives you a couple minutes. So thank you, everybody. Thanks for joining us. And Sam, we'll make sure we get you in. Look out for Sam, Amanda. Make sure he gets added to the Facebook group. There is a link in the email we just sent to the Facebook group also. So we've sent multiple emails to it. Maybe it's a problem on the phone. I don't know. I definitely don't go on Facebook in my phone either. So I'm not really a Facebook guru personally. Um, I don't use it, so hard for me to say. Anyway, this will be cool in the group though, because we do know how to do some of the group stuff, such as what do you call it? Uh, Such as doing a live demo. Okay, Sam, I'm just going to look for you in my, I'm going to look for you in Facebook and hopefully we'll get you in. Let me just screenshot your name. Not to worry, we'll get you in and there'll be the replay video there anyway. So Nahid, why don't you go set up and we'll wrap this up and that'll be good. So thank you everybody for attending today on a nice day here in North America, at least in our part of North America. And have a great weekend and we'll go from there. Thank you so much. We'll see
Okay.
you, Nahid.
Okay. See you in a bit.
Yep, see you in a bit. Okay, I'm going to shut down the webinar, everybody, and I'll hopefully, yeah, I'll shut it down. So leave.